uno,
lei uno,
poi c'è quello col suo nome.
no, c'è qua, sì, poi c'è,
Introduce quella mia.
da lì in poi
Lei è offline.
io vado via, lei si vedrà
Welcome everybody, and we are here in the city of Milano. The best of the year was planned in March 2020, but as we know, the pandemic started in the same days here in Milano. So we are here today and we wanted to create a human conditions with an aperitivo all together to celebrate that we are all together still in good condition during the pandemic. So I would like, first of all, to acknowledge the stellar panel who is joining me in these days, and they are friends, and they decided to join this particular Congress. And the Congress will be divided in 2 days. The first part is in the beginning, then there will be an interval, and during the interval there will be a cooking show with the possibility to join together and to toast together with the typical Italian and the typical Milanese aperitivo all together. The second part, I would like to acknowledge all these incredible people who are working with me in the last years. I had the incredible privilege to choose every one of these incredible people, and we had a wonderful time together. We are always happy together, and I would like really to dedicate this Congress to my group. So the young people of my team will have the privilege to chair this stellar panel, and we will be together, together here online. You can see all our pictures. We are a group. I hope that the tradition of our group will continue everywhere and in all the time that we will have all together. We like to celebrate and we like to have the aperitivo in Milano. So this is the reason why the Congress, maybe you received the box with the aperitivo. And so we hope that, unfortunately not alive, but we will have the possibility to join all together this part. I would like to acknowledge also the people from events. You were contacted in these days. It is very thrilling to have this event online because we know that it's scary. Sometimes we record it before our session, so it's thrilling, but they were incredible, and I just want to say thank you to the people of this group. I want to acknowledge also the people who decided to sponsor from the pharma companies these events. You can see listed on the left-hand side, and also all the scientific societies that endorse this important event. I don't want to steal other time from the work, and I hope that you will enjoy the day together, also tomorrow, and celebrate with us. I would like also now to give the word to the new chairs, Claudia Prota and Arsela Prelai, and I say goodbye.
Good afternoon, everybody. Thank you, Marina, for this unique opportunity. It is a great pleasure and honor for me and my colleague to start these 2 days of the virtual scientific conference. In this first session, we will talk about the recent advances in the treatment of oncogene-addicted non-small cell lung cancer. We will proceed first with all the presentation, and then we will have some minutes for questions and discussion. I have to ask you to stay on time because we have two very long sessions, but two very interesting sessions. Thank you.
So, good afternoon, everybody. I am very pleased to present the first speaker of this session, Professor Shirish Gaggil from Michigan. Professor Gaggil is the head of Michigan University, and he will today share with us the data on current treatment algorithms for EGFR mutated patients.
Claudio and Arcella, thank you very much for that kind introduction. Thank you to Marina. I wish I was there and watching you in that wonderful conference hall. I wish this was a live event, but anyway, this is a good option. And I would also like to thank the support staff that have coordinated this wonderful meeting. So my task today is to discuss EGFR mutated lung cancer. These are my disclosures. As is well recognized, one of the major advances in management of advanced non-small cell lung cancer is the recognition of targetable genetic alterations. And we need to recognize that the first targetable alteration was EGFR mutation. Before we get into the details, it is worthwhile to remind ourselves that there are many different EGFR mutations, and the biology of these tumors can differ. So the two major mutations, as is well recognized, are exon 19 deletions and exon 21 L858R point mutation, which constitute approximately 85 to 90% of all EGFR mutations identified in non-small cell lung cancer. But about 10% of the mutations, or a little under 10%, are exon 20 insertions in the EGFR tyrosine kinase domain. And then there is a smattering of other EGFR mutations. As mentioned, the EGFR mutation was the first targetable alteration identified in non-small cell lung cancer. And this sort of timeline shows the evolution of management of EGFR mutation positive stage 4 non-small cell lung cancer. Important to remember, particularly for the folks not as old as I am, where actually EGFR TKIs were first introduced into management of non-small cell lung cancer without any knowledge of EGFR mutations. It was the recognition of the selective activity of these EGFR TKIs, such as Gefetinib and Osimertinib, in patients who are never smokers and particularly of Asian ethnicities, that led to the identification of EGFR mutation in 2004. And after the identification of EGFR mutation as a driver genetic alteration in non-small cell lung cancer, there have been multiple trials that have evaluated initially first generation and second generation EGFR TKIs, and then subsequently introduction of Osimertinib, first for the management of T790M resistant mutation, and then subsequently in frontline setting. As is well recognized, first generation and second generation EGFR TKIs were compared in phase 3 trials to chemotherapy agents, and the TKIs demonstrated improved progression-free survival. What is important to note is none of these trials demonstrated overall survival advantage, though it is important to note that these trials were not designed to assess overall survival. The exception here is the dacometinib or the Archer 1050 trial, which compared dacometinib to Gefetinib and did show survival advantage. And I'll come to this issue a bit later on. The median progression-free survival observed with these first and second generation EGFR TKIs range from about 18 to 14 months. Now, the most common resistant mutation with first and second generation EGFR TKIs was the T790M mutation. Osimertinib, a third generation EGFR TKI, initially was developed primarily to address the T790M mutation. But it was quickly recognized that osimertinib can have good activity in patients who are treatment naive and have advanced EGFR mutation positive cell lung cancer. One thing I want to emphasize that when we are talking about these data sets, we are only talking about patients with EGFR 19 deletions and exon 21 L858R mutations. And I'll come to the other EGFR mutations later on in my presentation. So based on the activity of osimertinib as a T790M inhibitor in patients who had previously been treated with first and second generation EGFR TKIs, was evaluated as frontline therapy, and it showed a median duration of response of 19.3 months with a median progression-free survival of 16.7 months in this first study of approximately 90 patients. Based on these data, and these data looked better than what is observed with particularly first generation EGFR TKI, the FLAURA study was launched that randomized patients to osimertinib or first generation EGFR TKI, either gefitinib or erlotinib. The reason why both gefitinib and erlotinib were options is because this was a global trial, and in certain countries, gefitinib was a preferred EGFR TKI, whereas in the US, erlotinib, when the study was launched, was the preferred EGFR TKI. Patients were randomized, patients were stratified according to the EGFR exon or exon 21. No prior chemotherapy, no prior anti-cancer therapy was allowed, and patients with CNS metastases were enrolled on the trial. They could be treated or they had to be untreated. If they were untreated, then they had to be asymptomatic. The primary endpoint of this study was progression-free survival. And what this study showed, which is well recognized, and this is the figure to your left, which showed an improvement in progression-free survival, the primary endpoint, with a hazard ratio of 0.46 that translated into a median progression-free survival of 19 months with osimertinib, as compared to the standard first-generation EGFR TKIs of 10.2 months. It's important to note that whenever we look at a study that has shown a positive benefit, we need to ensure that the standard are performed as expected, and a median progression-free survival of approximately 10 months with gefitinib or erlotinib is what has been demonstrated in prior trials. When the first analysis was published by Soria et al. In New England Journal of Medicine in 2018, there was a hint that there may be a survival advantage as represented by the figure on your right. But this was only a trend at that point. And now we have the final analysis of overall survival presented by Dr. Ramalingam and subsequently published in the New England Journal of Medicine that showed that osimertinib did provide a survival advantage as compared to first-generation EGFR TKIs with a hazard ratio of 0.799 that translated into a median survival of 38.6 months as compared to 31.8 months with first-generation EGFR TKIs. What is important to note, apart from looking at the hazard ratio and the median progression-free survivals, is the survival difference at 3 years or 36 months. There was a 10% absolute improvement in survival. It's important to note that in this study, there was a crossover allowed. Of course, the crossover was only for patients who, after receiving first-generation EGFR TKI, had developed a T790M mutation. So not all patients were eligible for crossover. Only if their tumor had T790M mutation were they eligible. But nonetheless, despite a planned crossover, there was a survival advantage observed in this study. There are two important features of osimertinib, apart from the fact that it provided improved activity compared to first-generation EGFR TKIs, that are extremely important in its preferential choice, in this drug being the preferential choice for first-line EGFR mutation positive non-small cell lung cancer. One is a toxicity, particularly with skin rash. It is far less than what is observed with first and second generation EGFR TKIs. In fact, much less compared to second generation EGFR TKIs. In this particular trial, the incidence of diarrhea was not much different between osimertinib and patients who received gefitinib and erlotinib. I have to say that there was a higher proportion of patients who received gefitinib, a drug which is associated with somewhat less diarrhea. But I do believe that in the United States, where before osimertinib, erlotinib, and afatinib were the preferred drugs used, compared to those two drugs, the incidence of diarrhea with osimertinib appears to be far less. At least in my own personal experience, I have never started a patient other than maybe Imodium, never started a patient for any skin rash medications for patients who are on osimertinib, or to date have not discontinued a patient because of drug-related adverse event, at least in my own practice. And another important feature of osimertinib is its activity in the CNS. And though I could have shown you other clinical trial data, I thought I would like to highlight the CNS activity of this drug by briefly discussing a patient of mine who was, by the time she presented to me, in her mid-80s. She had already been treated with erlotinib for over 2 years, and then subsequently had been enrolled on a clinical trial of ruxolitinib, another third generation EGFR TKI, which has subsequently been discontinued. And so this patient had already been treated with two other drugs. And when she presented to us, overall, she was doing well. Ruxolitinib had controlled her disease outside the brain very well. But in the brain, she had multiple tumors. And I don't know how well this projects, but if you look at the images, both the top and the bottom on your left, it shows multiple small metastases. And these metastases were present in every cut of the MRI scan. This patient was started on osimertinib purely because of the progressive CNS metastases. And within 2 months on follow-up scans, there was complete resolution of these brain metastases. This patient continued to have brain control for over 2 years. Unfortunately, the patient subsequently died because of extracranial progression. And so I do believe that beyond the fact that it is an efficacious agent, its tolerability and its CNS activity are two important features of this drug. And it is in this context that we have to evaluate the data with second generation EGFR inhibitors when compared to first generation EGFR inhibitors, particularly of afatinib and dacomitinib. Specifically, I would like to focus on dacomitinib, which did show a survival advantage and actually a hazard ratio as represented on the farthest right column with the second last row with dacomitinib, a hazard ratio of 0.76, which appears to be somewhat better than the hazard ratio observed in the FLAURA study of 0.799. An important factor to note about the Archer 1050 study is it excluded patients with known CNS metastases, so it was a selective group. And there was 50% of the patients required dose reduction or dose discontinuation because of toxicity. And so based on those two factors, I do believe that osimertinib data does appear to be more promising and leads to a preferential use of osimertinib in the frontline setting. Now, it's important to note that when you look at survival, the primary endpoint of the FLAURA study was progression-free survival, and progression-free survival improvement was observed across all subsets. But when you look at overall survival, there were some subsets that did not appear to derive a significant benefit over first generation EGFR TKIs. So if you look at the second last row on this forest plot, showing the benefit in the subsets of exon 19 deletion and exon 21 L858R point mutation, it appears that the survival advantage with osimertinib compared to first generation EGFR TKIs were restricted to exon 19 deletion patients. Now, it's important to note that this is a retrospective subset analysis of a secondary endpoint and therefore has to be viewed with caution. And it is important also to emphasize that progression-free survival advantage was observed in exon 21 mutation. Nonetheless, what this data shows is that the benefit is not same across all patients with EGFR mutations. And so there is a need to see what can we do beyond osimertinib. And so there is an interest in evaluating combination therapy. One of the first sort of target that was evaluated in combination with EGFR inhibition is VEGF inhibition. It is well recognized that most tumors secrete angiogenic factors that induce neoangiogenesis and formation of vasculature. And so there has been an interest for a long time in targeting angiogenesis along with anti-tumor agents to improve activity of such therapy. And there is data to suggest that addition of anti-angiogenic agents such as VEGF inhibitors may be beneficial in EGFR mutation positive tumors. This is data from two separate trials, Beta and Zodiac, which evaluated the addition of a VEGF inhibitor in Beta to erlotinib and in Zodiac to docetaxel. And both studies suggested that there was an preferential improvement in patients with EGFR mutation positive non-small cell lung cancer. Based on the preclinical data, such retrospective data, there have been a couple of different studies that have evaluated the addition of bevacizumab or anti-VEGF agents such as bevacizumab to EGFR TKIs. The first study was the NEJ026 study from Japan that evaluated the addition of bevacizumab to erlotinib. And this study did show an improvement in the primary endpoint of progression-free survival with a hazard ratio of 0.605, which translated into a median progression-free survival of 16.9 months with the combination of erlotinib or bevacizumab. However, with longer follow-up, a survival advantage was not observed. Mind you, this was a secondary endpoint. However, it is well recognized that in several tumor types, the addition of VEGF inhibitors, particularly to chemotherapy agents, can improve progression-free survival, but this does not always translate into improved overall survival. There is another VEGF agent now evaluated in combination with EGFR TKI, which is ramucirumab, which unlike bevacizumab, which inhibits VEGF, this inhibits the VEGF-R2 receptor. And in this study, patients were randomized to erlotinib or erlotinib plus ramucirumab. It is important to note that this study excluded patients with baseline brain metastases. The primary endpoint of this study was progression-free survival, and it improved progression-free survival, though the median progression-free survival with the combination was quite comparable to single-agent osimertinib. The hazard ratio of 0.59 is not as promising as what was seen with FLAURA study with a hazard ratio of 0.46. In addition, we do not have the overall survival results with this combination. And so since osimertinib has shown a survival advantage, I would still preferentially treat patients with osimertinib. It is also important to note that in this study, you have to give an IV agent in combination with an oral agent. And there was some increase in toxicity with a higher rate of grade 3 treatment-related adverse events in the combination arm as compared to erlotinib placebo. So though this is a combination that is approved by the US FDA, in the United States, there appears to be still a preferential use of osimertinib as frontline therapy. Another combination treatment that has been evaluated in EGFR mutation-positive tumors is the addition of chemotherapy. This was the NEJ009 trial, again conducted in Japan, that randomized patients to gefitinib or chemotherapy plus gefitinib. The primary endpoint, again, progression-free survival, but what was impressive is that this study did show a survival advantage with a hazard ratio of 0.70. It is not clear how many patients had access to osimertinib when this study was being conducted. Nonetheless, an impressive survival advantage observed. A similar study from India again evaluated the addition of chemotherapy to gefitinib versus gefitinib alone. And this study was somewhat of a more real world study in that they allowed patients with brain metastases, and they also allowed PS2 patients. Almost a quarter of the patients enrolled on the study had PS2. Despite the fact that this study included chemotherapy. Now, the numbers may not be as well seen, and hopefully they are projecting a little bit better on the screen there. But with gefitinib alone, the median progression-free survival was 8 months, and the median overall survival was 17 months. These are somewhat underwhelming numbers, which have been reported in other trials with EGFR TKIs. Nonetheless, one needs to remember that this did include a quarter of the patients that were PS2. And combination of chemotherapy and gefitinib, the median progression-free survival was 16 months, and median overall survival was not reached. So we now have 2 trials that have shown improvement in overall survival with the addition of chemotherapy in treatment-naive patients to EGFR TKI. It is not clear whether we would see similar improvements in outcomes with the addition of chemotherapy to osimertinib, but based on the prior data, FLAURA 2 has been initiated that is evaluating osimertinib versus osimertinib plus chemotherapy. Now, it seems a bit of an overkill to treat all patients with either a combination with chemotherapy. Another combination treatment that is being evaluated is addition of a VEGF inhibitor to osimertinib. But it seems an overkill because there are clearly patients who do quite well with osimertinib alone. I have patients in my practice that are going on 4 years on frontline osimertinib. So is there a test we can do to identify patients who are at a particular risk of not having a good outcome? And maybe those patients are the ones that in whom we test the addition of a second agent to osimertinib. This is data from the FLAURA trial that evaluated circulating tumor DNA. And what was shown, if you look at the column on your left, that in about 32% of the patients, circulating tumor DNA was undetectable. But at week 3 and at week 6, a proportion of patients with osimertinib and with first-generation EGFR TKIs had clearance of their plasma circulating tumor DNA. And what was seen is that if you looked at the progression-free survival according to whether at week 3, the circulating tumor DNA that was detectable at baseline was cleared after treatment of 3 weeks with osimertinib or first-generation EGFR TKIs, it was identified that the patients in whom the circulating tumor DNA was not cleared had a worse progression-free survival. And it is possible that these are the patients that we evaluate the addition of a second agent like chemotherapy or anti-VEGF in preferentially rather than subjecting all patients to such combinations. And so it is possible that we may use circulating tumor DNA in the future. So this is the summary of first-line therapy. If osimertinib is available, in my opinion, osimertinib is the preferred agent. If osimertinib is still not available for frontline therapy, then in my opinion, at the present time, I would consider chemotherapy with an EGFR TKI inhibitor. One could also consider drugs such as dacometinib or afatinib, or the combination of erlotinib plus ramucirumab or gefitinib plus bevacizumab. I believe one of the most major presentations in the last 5 years in non-small cell lung cancer is the ADAURA trial presented at ASCO plenary session this year. We until now talked about the use of EGFR TKIs in the advanced stage, but this is now data adjuvant setting where patients with exon 19 and exon 21 mutation who were stage 1B to 3A were randomized to osimertinib or placebo. Osimertinib was given for 3 years. The primary endpoint was disease-free survival in patients with stage 2 and 3A disease. These are the baseline characteristics. I wanted to mention that each of the stages 1B, 2, 3A, about a third of patients were enrolled. Only 55% of the patients had received adjuvant chemotherapy, and 45% of the patients did not. And what this study showed that there was disease-free survival advantage across all stages, much more in stage 2 and 3A, with a hazard ratio of 0.17 and 0.12, and in 1B of 0.50. I would like to highlight the fact that in patients with placebo, the 3-year, the 2-year disease-free survival was only 32% in patients with 3A. And even in stage 1B, it was only 73%. So it shows that these patients are at a higher risk of progression. And so osimertinib, based on this data, is likely to get approval at least by several regulatory agencies, though one needs to be mindful that only 55% of the patients received adjuvant chemotherapy. The maturity of this data is only 30%. And this is disease-free survival, not overall survival. And the goal of adjuvant therapy is overall survival. But my suspicion is, based on these data, osimertinib is likely to be used in the adjuvant setting. And this does mean that in early stage lung cancers now, we have to do molecular testing to identify patients with EGFR mutations. I wanted to finish up by briefly talking about what is the data available for patients who have progressed on osimertinib, frontline osimertinib. Before I discuss the different options, I want to mention that we do have to take into account the clinical picture at the time of disease progression. There are some patients who have relatively slow progression, and these patients may not need immediate change in their treatment. In addition, there are patients who may have very limited sites of progression or may have CNS-only progression, and these patients could be managed by local ablative therapy. A change in therapy is particularly required if there is rapid progression or there is multi-site progression. Now, we are beginning to learn about the mechanisms of resistance to particularly to frontline osimertinib. This is data from the FLAURA study. This is blood-based analysis. This is not tissue-based analysis, and one needs to be mindful of that. But the two most common mechanisms of resistance were secondary C797S and MET amplification. C797S, interestingly, is sensitive to first-generation EGFR TKIs. The figure on the slide is a bit complicated. Suffice to say that in patients who have C797S after frontline osimertinib, preclinical data suggests that a combination of first-generation TKI and osimertinib may provide clinical benefit. Now, kindly note that we don't have significant clinical data to support this contention, but it is something that can be considered, a combination of first-generation TKI and osimertinib in patients who have C797S. In patients who have MET amplification, there is some data to suggest that the addition of a MET inhibitor such as savolitinib in combination with osimertinib in this statin trial showed a response rate of approximately 25%, with a median duration of response of 9.77 months. Now, this is only a modest benefit, nonetheless, a benefit that appears to be better than the other options. And therefore, if you do identify a MET amplification, one could consider the addition of savolitinib. Another agent is a bispecific antibody, JNJ372, that targets both EGFR and MET. And this combination showed activity in patients with resistance to osimertinib or first and second generation EGFR TKIs, irrespective of whether they had MET amplification or not, including in patients with C797S. So there is further study of this drug, but this drug could potentially be a treatment for patients who have developed resistance to osimertinib. Immunotherapy is definitely an option. The current data suggests that immunotherapy agents may not be as effective in patients with EGFR mutation positives. This was a small study of only 11 patients from UCLA that evaluated pembrolizumab as first treatment in EGFR mutation positive patients, but there was a response rate of only 11%. But what is even more concerning is that if you introduce EGFR TKIs such as osimertinib after patients have received immunotherapy, that they may be at an increased risk of toxicity, particularly pneumonitis. And so one needs to be mindful that one should not start treating patients just based on PD-L1 results, but await the results of molecular testing and start on appropriate targeted therapy first before treating such patients with immunotherapy agents. We do have some data of combination chemotherapy, immunotherapy, and an anti-VEGF agent that showed improvement in progression-free survival and overall survival in the Empower 150 study. But kindly note that there were only 50 patients with EGFR mutation. I want to finish up by talking about EGFR exon 20 mutation. As is well recognized, the currently available EGFR TKIs are not very effective. But at this year's ASCO, there were two presentations that evaluated different agents for EGFR with exon 20 insertion mutations. The first is osimertinib. Kindly note, this was at a higher dose of 160 milligrams. This was an ECOG study. And I know this probably is not projecting very well, but the response rate was about 24% rather, with a median progression-free survival of approximately 9 months. A small study of only 20 patients, but nonetheless suggesting that osimertinib at a higher dose may be beneficial. And a second, same agent, J&J 372, that targets EGFR, a monoclonal antibody that targets EGFR and c-Met. It has now a name, amivantamab, that showed a response rate of 36% in EGFR exon 20 mutations, with a median progression-free survival of 8.3 months. Further study is required for both these agents, but important to note that we may now have options for exon 20 EGFR mutations, which are traditionally resistant to the currently available EGFR TKIs. So in summary, this is where we are for the treatment of advanced EGFR mutation positive non-small cell lung cancer. Osimertinib is the preferential choice. If osimertinib is not available, one should consider using second generation EGFR TKIs or combination of chemotherapy with first generation EGFR TKIs or VEGF with EGFR TKIs. If the patient develops resistance to osimertinib in C797S patients, a combination of first generation EGFR TKI with osimertinib can be considered. I think my time is up, but I wanted to just finish up by saying we now do have data in the adjuvant setting with osimertinib and data with activity in exon 20 mutations. Thank you very much.
Thank you, Professor Gagil, for this complete presentation. Now we can go on with the next presentation. And I am very honored to welcome Professor Pilar Garrido from Spain. Professor Garrido is the head of the thoracic tumor section at the University Hospital Ramon y Cajal in Madrid. Thank you.
Hello, everybody. Can you hear me?
Yes.
Hello? Okay. My name is Pilar Garrido, as you said, and first of all, I would like to thank Dr. Marina Garasino and the full team for this kind invitation to be part of this amazing meeting entitled Cocktail with Science. I love the title, and my only pity is that we cannot meet face-to-face. I hope next year we will be able to do that. My talk today is about current treatment algorithm for ALK and ROS patients. These are my disclosure. Okay. As we know, I'm sorry, the previous slide. Okay. ALK is a distinct molecular subtype of lung cancer, as you know. The ALK gene belonged to the insulin receptor superfamily, was discovered in 1994 in anaplastic large cell lymphoma, and the first ALK rearrangement in non-small cell lung cancer was reported in 2007. From the clinical point of view, estimate prevalence of this subtype of lung cancer is about 2-5% of non-small cell lung cancer, mostly adenocarcinomas, and patients are usually never or light smokers, young, diagnosed with a stage 4 with frequent pleural and pericardial effusion, hepatic and CNS metastases. The first targeted agents was approved in 2011, and since then, many other drugs have been approved, and many others are also under development, meaning that this is an exciting subtype for lung cancer, but also really challenge for clinicians. I would like to briefly review different drugs and then talk about the different algorithms. Crizotinib, as I said, was the first drug approved in this scenario, and the clinical development was based on profile trials. The profile 1014 was a study in which patients were allocated to receive chemo or targeted agent, crizotinib, and this study showed a benefit in terms of response rate, median progression-free survival, and quality of life. And since then, crizotinib was our standard of care, and in fact has been our standard of care for many years. The long-term results of this study, sorry, because I have problem with the long-term results of the profile 1014 were published last year, demonstrated a benefit, not demonstrated a benefit in overall survival, but excellent overall survival in both arms. The problem with crizotinib is that in spite of having a median progression-free survival of 11 months, 60-70% of patients showed CNS progression due to the poor intracranial activity of this drug. Feritinib was the second drug approved in this scenario. It's a second-generation ALK-TKI. The clinical development was based on ACCENT program, which analyzed the role of feritinib in different scenarios. In treatment-naive patients, the study, the ACCENT-4, was also designed to test the role of feritinib versus chemotherapy. And the problem is the toxicity of this drug. Alectinib is also a second-generation. I'm sorry, what happened? Feritinib was tested against chemotherapy, but not against crizotinib. Next, alectinib is also a second-generation ALK and REC-TKI. The clinical development was also based firstly in ALK inhibitor naive, then in crizotinib pretreated, and finally alectinib was tested against crizotinib in 3 phase 3 head-to-head trial, ALEX, G-ALEX, and Alexia. The ALEX study, the global study, demonstrated an incredible median progression-free survival, 35 months, and a 5-year overall survival, recently updated in a paper published in Annals this month, of 62.5% versus 45%. So, at least in my opinion, currently alectinib is the standard of care, not only based on the efficacy result, the median progression-free survival, the long-term survival, but also based on the excellent CNS penetration and also in the tolerability. Brigatinib is another drug approved in this setting. It's a multi-kinase inhibitor. We have different studies. We learned from the very beginning in the clinical development of this drug that there is a risk of early pulmonary toxic event, and based on that, the initial dose recommended is 90 milligrams for 1 or 2 weeks. And then if the treatment is well tolerated, then is the time to move to the standard dose that is 180 milligrams. The phase 3 ALTA-1 study compared once again this drug, brigatinib versus crizotinib in treatment-naive patients, and once again the study, we can see that the study is positive with a median progression-free survival of 24 months versus 11 months. It's true that there is an ongoing phase 3 trial comparing brigatinib versus alectinib to second generation, but in the setting of patients and progress on crizotinib. And at least as clinicians, we would like to know the result of a face-to-face trial in the scenario of treatment-naive patient, because as I said, our current standard of care is no longer, at least in many countries, crizotinib but alectinib. Encertinib is another drug, recently updated results in the 2020 Presidential Symposium of the World Lung Cancer Conference. The EXALT trial demonstrated also a benefit in terms of median progression-free survival, 26 months, but this drug has a different toxicity profile, mostly rash and pruritus and liver function problem. And finally, the last drug approved in this scenario for now is lorlatinib. Lorlatinib is a potent, oral, selective, third-generation macrocyclic TKI active against all known resistant mutations for first and second-generation ALK inhibitor. Based on the phase 1 results, this drug was approved because was able to demonstrate a response rate 42% and a duration of response of 9 months after having received 2 or more ALK TKIs. But the truth is that we are waiting the result of the CROWN trial that will be presented during the presidential session next week in the ESMO meeting that compare lorlatinib versus crizotinib. We know, based on the press release, that this study is positive because lorlatinib resulted in a statistically significant improvement in progression-free survival compared with crizotinib. We also know that the toxicity profile of this drug is also different: hypercholesterolemia, hypertriglyceridemia, peripheral neuropathy, neurocognitive alterations such as depression, and also increased basal weight. I have problem. Okay, so if we want to start treatment with an ALK inhibitor in one of our patients, we have several options. We have 2 trials in yellow, the ones who compare chemotherapy versus first or second generation agents, and 4 studies in blue that directly compare first generation crizotinib versus second generation alectinib, brigatinib, or encertinib, or third generation lorlatinib. All the studies are positive with very good hazard ratio, and all of them demonstrated a benefit in progression-free survival. But it's true that the magnitude of difference in terms of PFS was different depending on the study. For alectinib, 35 months, for brigatinib, 24, for encertinib, 26, and as I said, we don't know yet the magnitude of benefit for lorlatinib versus crizotinib. So it means that it's a challenging decision for all of us, but it's also true that there are other things that we can take into account. We know that treatment success is more than survival, and we need to take into account the toxicity profile. Probably the drug with the higher toxicity profile is ferritinib. As you know, most of patients develop diarrhea and vomiting and nausea, and in fact, it's the drug that require stop the treatment or decrease the dose more frequently. But also there are other aspects that could be interesting and need to know that are, for instance, the pill burden. We know that when prescribing crizotinib, the patient will require 2 pills per day, ferritinib 3 pills per day, alectinib 8 pills per day, brigatinib and lorlatinib only 1 pill per day, but also could be relevant to know the potential risk linked to drug interaction. And in this aspect, alectinib is the winner because according to clinical study, there are not clinical meaningful drug interaction observed with this drug. So it's also a fact that could be important for some patients. Yeah. We don't know yet if a different variant of ALK rearrangement pattern can be of value in clinical setting. We know that there are more than 19 different ALK fusion partners. The most common is EML4 gene because ALK and this gene both are located on the short half of chromosome 2. We know that the breakpoint of ALK gene is usually located at exon 20, but we also know that EML4 breakpoint differs to generate different fusion protein variants. We know that the more common variants are 1, 2, and 3, but we don't know yet if the expression of a particular variant may influence outcomes depending on the ALK inhibitor and or the development of some specific secondary ALK-resistant mutation. As you can see in the slide, in the pie in the middle of the slide, depending on the variant, you can see the pattern of different resistant mutation. From the clinical perspective, we only have data coming from exploratory analysis of some randomized clinical trials. For instance, last year were published the analysis based on Alex study, showing that the PFS was similar with alectinib across all different fusion variant analyzed. However, the ALTA-1 study, the results related to the different variants presently during the last ASCO meeting, it seems that maybe the variant 3 has some prognostic value, not predicted, but prognostic. We know that all our patients will develop a resistant disease, and we don't know what is the best strategy after progression on upfront second generation. As I said, because I consider that in most of our countries currently alectinib is the drug to be used upfront. We can follow the guidelines, and according to the ESMO guideline updated for the last time in September last year, we have several options. But we also have some algorithm in which the idea is to use different drugs depending on the result of repeating a biopsy. So we don't have a strong clinical support to do that, but we know that there are some protocol, some studies ongoing, such as this ALK Master Protocol sponsored by NCI, in which patients, after receiving upfront a second generation AN, will be located to different ARC to receive different drugs depending on the resistant mutation, or the alkaline trial from the ERTC group, in which all patients receive lorlatinib, but this study will assess the impact of liquid biopsy to evaluate the emergence of resistant restoration. We can, as clinicians, we cannot wait until knowing the result of these studies ongoing. We need some answer for our patient. And one of the questions is, what is the efficacy of a second generation after a second generation? For instance, what is the efficacy of brigatinib after alectinib? And in this scenario, we have two studies, a retrospective study and a prospective study. Retrospective study is a collection of information about 22 patients from three very good institutions in the US, in which patients receive TKI, and they were analyzed the result of brigatinib after receiving alectinib as prior treatment, 86%, or other TKIs. And as you can see on the left part of the slide, the response rate of brigatinib was only 17%, and the progression-free survival only 4 months. And in fact, the only patient who had the most resistant mutation linked to the activity of alectinib show progressive disease in the first assessment after using brigatinib. However, based on the prospective data presented during this ASCO meeting, we can see that the efficacy of brigatinib after alectinib could be in a range of a response rate of 34%, a median progression-free survival of 7 months, and in this particular trial, the 3 patients who had the same mutation achieved a confirmed partial response. So maybe there is a role for brigatinib in this scenario. Also, as clinician, I think it's important for us to know the role of chemotherapy. We know that platinum pemetrexed is an active combination in lung cancer, and in particular in the setting of ALK patient at front, the expected progression-free survival is about 7-8 months based on the control arm of Profile 1014 and ASCENT-4 trial. However, based on this retrospective analysis, when you use chemotherapy, once all the options using TKI are exhausted, the PFS expected is only 4 months. And very interesting in this small retrospective study is that those patients who receive chemotherapy plus ALK inhibitor, in this particular patient, the progression-free survival was longer. So I think this is an area that deserves further investigation because we need to act in this situation. Finally, I am not going to talk about immunotherapy because of the time, but I recommend you this review that is an educational session for the last ASCO meeting, in which we can summarize by telling that the result of immunotherapy are really disappointing in ALK patients. So now I would like to move only 5 minutes to talk about ROS disease. As you know, ALK and ROS1 fusion kinase have a high degree of homology, meaning that most of the active drugs are useful in both situations. But it's important to remark that alectinib is a notable exception, lacking of ROS activity, while cabozantinib, an agent that could be useful in ROS disease, is active in ALK patients. Crizotinib was the first drug approved in this setting based on the result of a phase 1 study showing excellent progression-free survival result, 19 months, but it's true that was approved without having a randomized clinical trial in comparison to chemotherapy. Other drugs is, for instance, ceritinib, and it's key to remind that ceritinib seems not to be effective in crizotinib pretreated patients. It's a drug highly active in treatment-naive patients, but not in crizotinib pretreated. While entrectinib shown similar results, is active in TKI-naive ROS-positive patients, obtaining very good results, but has not shown activity in patients previously treated. There are 2 drugs that have been demonstrated some value in this scenario. One is lorlatinib, that is active in TKI-naive, but also in crizotinib pretreated patients. But the truth is that the results are not similar. The efficacy in TKI-naive is response rate 62%, median progression-free survival 21 months versus response rate 35%, and median progression-free survival only 8.5% in crizo pretreated patients. And finally, repotrectinib, I cannot move. Yeah, repotrectinib, that is a novel next generation ROS, NTRK, and ALK TKI specifically designed to overcome this the resistant mutation. The activity in TKI naive is high, 82% of response rate, versus in TKI pretreated response rate 40%. So we have several options again, but the responses seems different depending on using in the first line setting or in pretreated patient. As I said, crizotinib, feritinib, entrectinib, lorlatinib, and repotrectinib are active upfront, and only lorlatinib and repotrectinib in pretreated patients. So in summary, my last slide, ALK and ROS define a small but significant subset of patients for which targeted agents are highly effective but clinically and biologically heterogeneous. We have a growing menu of ALK and ROS TKIs that vary in chemistry, potency, efficacy, CNS penetrance, and toxicity, and we need larger study to determine whether ALK and ROS mutations, the specific type of rearrangement, and other genetic alteration could serve as predictor of response or resistance to TKI. So thank you so much for your kind attention.
Thank you, Professor Garrido, for this wonderful presentation. And so we can remain connected with Spain, because I am very glad to present the next speaker of the third speech, which is Professor Enriqueta Felip from Barcelona. She is the head of the Thoracic Cancer Unit of Vall d'Hebron University Hospital, and she will talk with us today about a very interesting speech, which is target therapies beyond EGFR, ALK, and the ROS1 mutation.
Thank you, Dr. Prelaz, Dr. Proto. I would like to thank my dear friend Marina Garasino for her kind invitation, and also for the opportunity to be with you today. So, as my disclosures. So today I'm going to briefly summarize what is the situation of number of targets in patients with non-small cell lung cancer, BRAF V600, MET 14, HER2, NTRK, and KRAS G12C. So I'm going to start with BRAF. So BRAF mutation is present in approximately 2% of non-small cell lung cancer patients, and in lung cancer, from all patients with BRAF, 50% had the B600 mutation. That is really the target in studies using targeted agents. This is slightly different of what we are seeing in patients with melanoma, in which 70% of those patients with BRAF mutations have the B600. And we have seen the results of dabrafenib in patients in second line with BRAF V600, showing a 33% response rate and also a median PFS of 5.5 months. The next step was to analyze the combination of dabrafenib plus trametinib in the second line of patients with BRAF V600, also showing a 67% response rate and a median PFS of 11 months. Dr. Carr also published the results of the combination dabrafenib plus trametinib in first line in patients with BRAF V600, showing a 64% response rate and a median progression-free survival of 10.2 months. And in the majority of guidelines, and including the ESMO guidelines, there is a recommendation for testing for BRAF in patients with lung cancer, and for those patients with BRAF V600, there are two potential first-line treatments, dabrafenib, trametinib, or platinum-based chemotherapy, but the ESMO guidelines recommend dabrafenib, trametinib second-line for those patients not being treated with this combination in first-line. Let's move on to RET. So RET fusions are seen in approximately 1% to all non-small cell lung cancer, but if we analyze those patients, never smokers, and pan-negative for EGFR, ALK, and ROS, the incidence is approximately 15%. There are a number of fusion partners, and when we analyze the patient's characteristics, we can see that patients with RET fusions have a younger age at diagnosis. There is a majority of never smokers and with poorly differentiated tumors. At diagnosis, approximately 25% of the patients had brain metastases, and for testing, we can do using FISH or NGS. And we have two highly active agents for patients with red fusion non-small cell lung cancer. The first one is selpercatinib, LOXO-292. The results of this agent in patients with red fusion positive non-small cell lung cancer have been recently published in New England Journal of Medicine. The investigators included 100 patients previously treated with platinum-based chemotherapy, showing a 64 response rate with LOXO-292 and a median progression-free survival of approximately 17 months. There is a group of patients, 39, previously untreated, and the median duration of response was not reached. Importantly, this agent was associated with a CNS activity. The second agent is pralsetinib, BLU-667, also analyzed in red fusion positive non-small cell lung cancer patients in the phase 1/2 ARROW trial. And in this trial, 92 patients previously treated with platinum-based chemotherapy were included with a 55% response rate, and also 29 patients treatment naive with a 66% response rate. The median duration of response was not reached, and again, CNS activity was seen with this compound. At present, we have 2 randomized trials in patients with red-positive tumors up front, comparing these 2 agents against chemotherapy or chemotherapy plus immunotherapy. The next target that I would like to discuss with you is a MET exon 14. MET exon 14 is present in approximately 2% of non-small cell lung cancer patients, and the patients have a slightly different clinical features. So we can see MET exon 14 in older patients, smokers with sarcomatoid differentiation, and also we have up to 20% of patients with MET exon 14 skipping mutations with concurrent MET amplification. We have type 1 TKIs that bind the ATP binding pocket inductive conformation. And today I'm going to review the results with 2 agents, capmatinib and tepotinib, for these patients with MET exon 14 skipping mutations. Sorry. And again, I'm going to review 2 papers published in the New England Journal of Medicine. So capmatinib has been analyzed in a phase 2 trial, the Geometry Mono 1 trial, that is a phase 2 trial with a different cohorts of patients. MET exon 14 were included into cohorts. I would like to highlight here the cohort 4, including patients with MET exon 14 previously treated with chemotherapy, and capmatinib achieved a 41% response rate in this group of patients. There is also the cohort 5B, including patients with MET exon 14 treatment naive. In this trial, 28 patients were included in this cohort, and the response rate was 69% using capmatinib. And we have also information about progression-free survival with capmatinib that was 5.4 months for those patients previously treated, and 10 months for those patients treatment naive. The study was also analyzed in a cohort of patients with MET amplification. For the patients with MET amplification in second or third line, capmatinib was associated with a 29% response rate and a median progression-free survival of 4 months. For those patients with MET amplification in first line, 15 patients, the response rate with capmatinib was 40%, and the median PFS was 4.1 months. So moderate activity in those patients with MET amplification. The tepotinib drug has been analyzed in the Vision study, a phase 2 trial, also with 2 different cohorts. The cohort A included patients with MET exon 14 skipping mutations, and the cohort B included patients with MET amplification. The results in cohort A with MET exon 14 skipping mutations, again, recently published in New England Journal of Medicine. One important aspect in this trial is that patients were selected based not only in tumor tissue determination, but also in plasma, in liquid biopsy determination. So the response rate for those 99 patients with liquid biopsy and tissue biopsy determination was 46%. For those patients with MET-exon 14 in the liquid biopsy, the response rate was 48% with tepotinib, and for those patients with MET-exon 14 in tissue biopsy, the response rate with tepotinib was 50%. And also we have information about progression-free survival that was 8.5 months. For those patients in the combined biopsy group, it was 8.5 months for those patients in the liquid biopsy group and 11 months for those patients in the tissue biopsy group. And as I mentioned, in the VISION trial, liquid biopsy was important not only as a tool for inclusion in the trial, but also there are 51 patients with matched baseline and on-treatment biomarker profiles from liquid biopsy. 51 patients, we have this correlation. 67% of them had molecular circulating free DNA responses, meaning a decrease in the allelic fraction. And we have seen that for those patients with a molecular circulating free DNA response, the radiographic response rate was 71%. HER2 is also another important target in patients with lung cancer, and we have studied HER2 for a long time. We have different mechanisms of activation of HER2 in patients with lung cancer. We have protein overexpression, immunohistochemistry 2+ or 3+ in approximately 12 to 20% of the cases. We have activating HER2 mutations in 2% of the patients, and we have also amplifications in 3 of the patients at diagnosis and around 10% of cases of EGFR TKI resistance. And in general, HER2 amplification and mutations do not usually occur together. So we have 2 main questions in patients with lung cancer: how to define HER2 positive lung cancer, and also which patients are suitable for treatment with anti-HER2 agents. And we have analyzed a number of TKIs in patients with HER2 mutations, and overall, the results are not clearly positive. So the ETOP group has analyzed afatinib in patients with HER2 mutations, a phase 2 trial, including 13 patients treated with afatinib. The first stage stopping boundary was crossed when 5 of 9 patients did not achieve disease control at 12 weeks. The accrual into the trial was stopped, and the median PFS was only 15 weeks. And in this trial, afatinib did not show the expected potential for disease control in non-small cell lung cancer. But we have also information with neratinib in the SUMMIT trial, a basket trial, and there are a cohort of patients of 26 with HER2 lung cancer mutated, and only 1 patient, 3%, had a partial response. TBM1 is active for patients with HER2 mutations. There is a publication in JTO, including 18 patients treated with this ADC. 44% of patients had partial response. The median progression-free survival was 5 months, and there was a concurrent HER2 amplification in 2 patients. But probably HER2 immunohistochemistry, at least 2+, is not enough to predict the response, at least with TBM1. There is one phase 2 study analyzing TBM1 in patients with immunohistochemistry 2+ or immunohistochemistry 3+ for HER2. No responses were observed in the cohort of immunohistochemistry 2+ cohort, and 4 partial responses were observed in the immunohistochemistry 3+ cohort. And 3 of 4 responders had concomitant HER2 gene amplification. And probably one of the most important presentations this year at ASCO meeting was the DESTINY-Lung01 study analyzing trastuzumab deruxtecan in patients with HER2 mutations. In this trial, there are two different cohorts of patients. The cohort 1 is including HER2 expressing tumors, immunohistochemistry 3+ and immunohistochemistry 2+, and we don't know the results from this cohort, but Dr. Smith presented the results in 42 patients with HER2 mutations, and we have seen a 62% response rate. The median duration of response was not reached, and the estimated median progression-free survival was 14 months, so very good results in these patients. Dr. Gatchell mentioned the patients with EGFR exon 20 insertions. He reviewed the results with osimertinib. Also, we have results with poziotinib in this group of patients with a 55% response rate and a median PFS of 5.5 months with TAC 788. And also, he reviewed the results with amivantamab. NTRK is also important in patients with lung cancer. We know that we have several fusion partners, and also we know that there are different histologies with the possibility to have NTRK alterations, salivary tumors, secretory breast cancer, thyroid cancer, lung cancer, and also we can see these molecular alterations in different ages, including pediatric tumors. And we have two main agents for patients with NTRK, larotrectinib and entrectinib. The results of larotrectinib were updated during the ASCO meeting. 116 patients were included. Very amazing response rate, 71%, even for those patients with CNS involvement. And also, we have seen responses irrespective of the tumor type. And they presented median duration of response of 25 months, median progression-free survival of 25 months with this agent, and also median overall survival that was not reached. We have also data with entrectinib, updated by Dr. Rolfo during the ASCO meeting. Again, a very active agent, entrectinib in patients with NTRK. 74 patients were included. The response rate was 63%, and also there were responses in patients with CNS metastases and without CNS metastases, and irrespective of the tumor type. And again, median PFS of 11.2 months and median overall survival of 23 months. So very active agents in this group of patients. And also we have a second generation NTRK inhibitors. We have results with LOXO-195, 31 patients previously treated with a prior TKI with a 34% response rate. One important issue with NTRK is testing, not only with NTRK, but with NTRK I think it's more important because we are including not only patients with lung cancer, but also other patients in which NGS probably is not a standard of care. And according to a paper in Annals of Oncology, if NGS is standard, this should be the method for testing, but if not, perhaps we can use immunohistochemistry and then to confirm using NGS. Finally, I would like to mention KRAS. We know that KRAS is present in 20% or 30% of lung adenocarcinomas. The KRAS G12C occurs in 13% of non-small cell lung cancer, and we have AMG 510 that is a covalent irreversible inhibitor that permanently inactivates the mutated KRAS G12C protein. And we have seen during the World Conference in Barcelona the preliminary results of the phase 1 trial presented by Dr. Govindan in patients with lung cancer, achieving a response rate of 48%, and some responses were long-lasting. And at present, we have randomized trials in second line in those patients with KRAS G12C mutation. So we have discussed immunotherapy. For those patients with BRAF, the immunotarget show a 24% response rate with immunotherapy. For those patients with MET, 16%. However, low responses for those patients with HER2 and also with RET. For MET, we have this paper analyzing, presented, published in Annals of Oncology. Those patients with MET exon 14 probably have a high incidence of high PD-L1 status. However, the TMB is lower when compared with unselected non-small cell lung cancer. But we have a presentation during the World Conference in Lung Cancer that perhaps for those patients with BRAF mutations, these are patients sensitive to immunotherapy, and there is this MD Anderson cohort in which the PFS with immunotherapy was 7 months. My last slide is about testing, because testing is a challenge in a majority of countries, and more when we are dealing with these molecular alterations. And according to a survey from the International Association for the Study of Lung Cancer, the 3 top barriers for testing are cost, quality, and access. So let me finish by saying that at present non-small cell lung cancer is divided in subsets by presence of targetable molecular alterations, not only EGFR, ALK, and ROS, but probably BRAF V600, MET, RET, HER2, NTRK, and perhaps KRAS G12C. We have cohorts of these patients with very good PFS and overall survival in clinical trials. We know that for targeted therapies is important the potency, selectivity, toxicity, as mentioned by Pilar Garrido, and also CNS penetration, but we have challenges when we are dealing with these uncommon molecular alterations, having availability to NGS in tumor and also in liquid biopsy, and also have available treatment option for patients with molecular alterations. And again, thank you so much for your kind invitation.
Many thanks, Professor Philippe, for this overview on the new driver alterations. Now let's go to the final presentation, and I am very glad to introduce the next speaker, Professor Christian Rolfo from Maryland. Professor Rolfo is the chief of the thoracic clinical oncology and the early clinical trial at Maryland University in Baltimore. He will discuss on the role of the liquid biopsy on detecting and monitoring tumor with driver mutation.
Hello, good morning. Thank you very much for the invitation. Thank you, Marina Garasino, for this incredible meeting. Next time, I hope that we can have the aperitivo a Brera and not by internet, but it's a very nice meeting and I'm very glad to participate here. Thank you, Dr. Prelay and Dr. Proto, for the introduction. So I will go for my disclosures. The first one. Those are my disclosures. When we are discussing about liquid biopsy, before to go for this interesting topic, we need to remember what Enriqueta Felipe was telling right now, that the testing is still a problem, and unfortunately, several patients are not arriving to the consultation, clinical consultation, with a next generation sequencing done. So we need to be very conscious about that, and liquid biopsy is contributed in this in a very well manner, giving us to the possibility to treat our patients with a really robust data and concordance with tissue. This is the ideal situation of the liquid biopsy. Obviously, we would like to have a method that is coming from the screening until the resistant monitoring, passing for other scenarios like minimal residual disease and recurrence of therapy. But it's not so easy. Liquid biopsy was doing gigantic steps in this direction, but still there are things that we need to refine to be applicable in all the scenarios that we would like to have. It's true that in the scenario of the early lung cancer detection, there are very good news. Recently, we're publishing two important articles that I suggest to read. One is from Annals of Oncology with the method of the methylation analysis of the free DNA, and the second one is from a group of Maximilian D. that was from Stanford that was published in Nature, and this is the plasma and leukocyte DNA analysis. And with this, in incorporation with the low-dose CT scan screening, we can have the opportunity to help a lot of people and save a lot of life in the early lung cancer detection. That is just to open the new frontier. One of the concepts that Dr. Felix was also discussing was the allelic fraction variation, and we saw that is applicable in several studies. What means allelic fraction variation is the minimal quantity of DNA that we will have to detect the alterations or the aberrations that we want to target. For example, we can have range from 0.1% to 90%. That depends obviously of the coverage and also depends of the deeper of the analysis that we go with the vendor or in-house testing. There are several things that we need to remember when we are speaking about liquid biopsy. Depends of the site of metastasis that we will have, the burden of the disease, the quantity of DNA that we are able to catch, and also very important concepts when we are working in in-house method. We need to be very careful with the pre-analytical condition for the test. So if you are taking a blood and you are living there for 3-4 hours and then you send to the with not the proper tube and you are sending to the lab, obviously the quantity of DNA that you will have is less or is alterated, and the results obviously will be very different to the when we are doing the correct one. Actually, there was a recent publication from BloodPack that is in a group here in the United States that is a consortium trying to generate data for pre-analytical analysis, and I recommended also to follow this because are very good clinical inputs or clinical insights for the analysis when we are using in-house method, and that is specifically a reality that we have not here in the United States because we have access to the with the two new FDA approved liquid biopsy tests. But in Europe, I know that there are several centers that still are using in-house technology, so it's important that we be very careful with this pre-analytical condition. One of the new frontier is the immunotherapy, obviously. I will not talk about the immunotherapy and liquid biopsy, but we are still in the beginning. The only thing that we was able to do with liquid biopsy in immunotherapy was the tumor mutational burden in the biopsy. We are trying now to take also some advantage information from the new mutations like KEAP1 or ARIAD or STK11 that we can check this in the liquid biopsy, but still there is a long road to follow to make the liquid biopsy a trustable tool in immunotherapy. Going to the topic of this session that is specifically the target, we know that the NCC guidelines are including right now several topics and several targets. Sirish Gadgel was speaking about EGFR, Pilar was speaking about some of them, Al-Cross, and Enriqueta include the other ones that we have nowadays, important advance in the therapeutic session. So it's very important that we test our patients, and we know that unfortunately in liquid biopsy in tissue we are not able to catch always the quantity that we need to do not only a single determination but the panels that we need to cover all this next generation sequencing. In the guidelines, the NCC guidelines, ASCO and American Pathology Society included the liquid biopsy as a reliable tool, so we are able to use that. And ISLC was creating in 2018, we published the first statement paper about the liquid biopsy. And even though that we are now trying to get a second version, so we are preparing the second version right now. At that moment, we were suggesting to start with tissue and then going for liquid in case that you have some patients with target mutations that you are not able to catch that in liquid. So this is now we are changing, and I will show you why we are changing. Because the robustness of the study, for example, the Nile study that was giving an idea here in the beginning, they obviously confirmed what we say, that the next generation sequencing is not really possible in all the patients. And we have also some patients that they can have false positive or false negative, because we are not catching also the heterogeneity of the situation in the biopsy, in the tissue biopsy. We know at that moment in this study that the addition of free DNA is able to catch 80% of the sensitivity of the 8 guidelines recommended biomarkers, and also the turnaround time, obviously, that is a very important point when we are treating our patients, that sometimes they are coming from evaluations until they arrive to our consultations. They were passing for pulmonologists, biopsies, and so on until they arrive. So the idea to do a faster next generation sequencing analysis is very important. And obviously, when we add liquid biopsy to tissue, the increase of the detection was given in a 48%. So the idea to go for blood first is one of the most important concepts that we are trying to pursue it right now with liquid biopsy. Sirish Gadgel presented this data last year, and it's the first prospective analysis that we have. It's a very elegant trial. You have here several of the targets that we are now using, but we know the first part of this analysis, that is the ALK, and all the patients have like an only source the biopsy, the liquid biopsy, free DNA in this case, and were treated with alectinib in the case of ALK positive. In this data confirmed that the high response rate are very similar to the ones that we observed in the tissue, and that's, for example, the parallelism with the ALEX trial. Overall response rate in that case was 71%, and here we are talking about the similar situation. So robustness about the liquid biopsy as a reliable tool before going to tissue in some cases. The allelic fraction variation that I told you, that is the minimal quantity of DNA that we need to have to determine that this alteration is there, sometimes is a problem for some of the doctors, because they say, okay, we have a report that is 0.01 and it's a ROS1. What I need to do with this patient, I consider positive or not. So if you see in the graphic, majority in this waterfall plot, majority of the patients are responding, and in the graphic that is in the other side, you see the correlation from the RECIST and the allelic fraction variation. So in the minimal allelic fraction variation, that was the majority of the patients, was a reduction of the RECIST. So it's not important the quantity of the allelic fraction variation when you are in front of a driver. It's important that you are able to treat these patients properly. There are also important concepts when we are trying to determine targets, and is the time point that we are taking the blood. And obviously there are, if we are treating a patient, for example, with osimertinib, and because the patient was treated in second line, for example, with T17IM, and we are having a reduction of the clones of T17IM, will be very difficult that we are catching a big populations of free DNA, and also reliable to have the results. It's important that we are also consider that when we are doing radiotherapy or chemotherapy, the quantity of DNA that will be higher for the reason of the inflammation and also the necrosis that we are producing could be not the one that we want to catch for the analysis. So that's our concepts that are very important. In the FLAURA analysis, we learned also another concept that was preliminary data in some Korean studies, and that was the clearance of the EGFR, so the detection of the mutation in the blood is a predictive biomarker. So after 6 weeks of treatment, patients who are decreasing the EGFR detection and became undetectable, have an impact in the progression-free survival, and that is a very important concept that we need to have, because we are impacting also indirectly in the analysis of, for example, CT scan and extra CT scans that we are doing in our patients. And so this is a very interesting thing that is opening the concept of monitoring of EGFR. And obviously, what is the advantage when we have a liquid biopsy over the tissue? That we are catching the intratumor and intrapatient heterogeneity. And this is a very important concept, because nowadays we are not only focusing on determining the target, but also the commutations that are companion of this target. When we have, for example, patients who have an EGFR mutation, but is coming with a TP53 or an EGFR amplification, we know that these patients have a prognosis that is poor compared with another patients who have not this companion mutation. So I always compare that with the bus and the drivers and the passengers. So we are now focused also in the interior bus, taking the information of the passengers as well. And we arrived to the honeymoon killers, unfortunately, that are the mechanisms of resistance. And here we need to identify exactly which kind of mechanism of resistance we have in order that we are going for the right decision for this patient. And this is the case that we have here also in the guidelines. We went directly for liquid biopsy at that moment, and I think we will maintain this in our recommendation, because is the way that we want to catch this analysis in the patients who are having TKI progression. Obviously, if the patient have a non-target resistant mutation at the moment that we are doing the liquid biopsy, is recommended, is highly recommended, a tissue rebiopsy. Also because we are catching other mechanisms of resistance like transformation, histology transformation. And in the FLAURA analysis, we learned that not only when we are passing osimertinib to the first line, like Sirish was explaining, we are not only focusing the traditional T790M, but we are focused more in other mechanisms of resistance, and 797, that is still a medical need, is one of the mechanisms of resistance, but surprisingly, in this trial, we have the MET amplification around 50% as a mechanism of resistance. So we are able to catch also MET amplifications in the liquid biopsy. Obviously, it's important that we are focused also in the ratio of this amplification if we want to have a good response of the treatment. And sometimes that is not feasible with the liquid biopsy, so we need to go for tissue confirmation in that cases. But for example, ERT amplification as well could be, or BRAF oral could be catching perfectly. I want to show you one of the cases. This is a 47-year-old female with adenoid-squamous carcinoma, and when she was discovered, this is when she had the diagnosis of the disease, she had, like you can see in the images, and a big metastasis in the liver and a primary in the lung. She had an EGFR mutation, and this is the concept that I repeat before, TP53 TP53 mutations, PI3 kinase mutations, and also another EGFR mutation that was in the exon 3 were present at the moment of the diagnosis. We started with osimertinib. She had a good response. You see here in the lung, partial response also in the liver, and a reduction, if you see in the graphic, the reduction of the allelic fraction variation from 9.8 to 0.3. She have later on a progression of the disease, and at that moment in 2018, we was discussing to have afatinib as an option of patients with 797S. That was the mechanism of resistance that we have. We know nowadays that it's better for TKI of first generation, and then we switch finally to chemotherapy. The patient was not accepting chemotherapy in the first option, so we switched finally to chemotherapy, and she had a good response with chemotherapy. And you see at the moment of the maximal progression, she had an EGFR amplification and other alterations that are also involved in the bad prognosis of the disease. This is what we call a clonal evolution of the disease, and that is the pre-existing resistance that is emerging with a new mutation. That is the case of the EGFR C797S that is coming as ex novo. And I want to also give you another case that we are checking also MET amplification. For example, this is a patient that was receiving Osimertinib in second line after progression of afatinib with T17IM, as you can see in the graphic there. Important metastasis in the bone, in the calvarium. She started Osimertinib, and then we started with Osimertinib. She have a reduction. You see T17IM was not more detectable, but the MET amplification was highly expressed. At that moment, she had a progression in the symptoms, neurological symptoms, and we started, because we don't have a clinical trial, Osimertinib and crizotinib in combination. And after some months of treatment, she was having a non-detectable alterations with an important progression-free survival and improvement of the symptoms. So is that what we discussed, pre-existing mutations? When you have, like here, MET amplification was present at the very beginning with EGFR, but the lead of the progression is taking one clone over the other, and the idea that we are monitoring and adjusting the treatment in time is very important. I told you that 797S is an unmet medical need. We don't have, unfortunately, any drug that is covering these alterations. We can go for preclinical data in combinations, depending or not if you have the T17IM presence, and that is the case, for example, if this is a case that is very similar to one that I have in clinic, and patients who start with Osimertinib have a 797S. When they don't have T17IM, the idea to back to EGFR of first generation TKI is very important, attractive, and you can have obviously a response, but you need to remember that you are pushing also mechanisms of resistance that are coming typical for the first generation TKI. And this is the case here, allelic fraction variation decreasing, but increase of the T790M as a mechanism of resistance of erlotinib. So we need to continue to monitoring that patients. Pilar Garrido was speaking about this ALK algorithm. We have nowadays also ensartinib that was recently approved, and it's important that we are catching the mechanism of resistance because we have different mutations. This is the example that also Pilar showed, the NCI-ALK protocol, that we have different mechanisms of resistance that are not only the acquired resistant mutations, but also MET amplification that in this trial are covering. So it's very important. The concept of ALK rebiopsy or liquid biopsy was not used before. We was using that only for EGFR, but nowadays we have an option also for these patients. The transformation, I told you that is also an important mechanism of resistance. We are not only speaking about a small cell transformation. Our patients in the 15% of this trial that was published recently in Clinical Cancer Research showed that also patients can have a squamous transformation or pleomorphic transformation. So it's important that we are catching that. How liquid biopsy can help us. For example, if we have patients that they don't have in the very beginning, or they have in the very beginning retinoblastoma 1 and TP53, the loss of these two biomarkers in the blood could also, obviously this is an indirect assumption, but is speaking as a possible small cell lung cancer transformation, but also the acquirance of these two mutations during the mechanism of resistance during the process of treatment as a mechanism of resistance is very important. So it's important when we are talking about next generation sequencing in tissue, but also in liquid, that we are considering different things, the assays, especially when we are talking about in-house assays, the commercial versus the in-house, there have different quality controls. We need to be very careful about the limit of detection, the enrichment technology, especially if we want to catch some of the new fusions, like a red fusion, for example. If we don't have a good enrichment technology to the NGS addition, that will be a problem. The hybrid capture is one of the enrichment technologies that we are using. And that is very good example what is happening, for example, now with track. Some of the vendors, they are not covering all the three genes, and track 1, 2, or 3. They are only covering one because obviously you need a big panel or a big capacity of the panel to include all the variability of the fusions that you have for these genes. So we need to know the limitation of the detection that we are working with. We need to know the sensitivity, the specificity. If we are doing in-house, it's important that we have a very good bioinformatics analysis, the interpretation and the reporting. So the idea to use, for example, molecular tumor boards to interpret and the data that are reported by the companies, and also to know which kind of calls are really variance errors or not, and obviously the time and the cost. And finally, for the limit of the detection, I want to give some insights about the technologies. We started in the beginning with liquid biopsy with a very poor technology that was the Sanger, that was that we have at that moment. Nowadays we are speaking about high throughput, optimized next generation sequencing. That's the case that we are doing next generation sequencing as a panel. There is the possibility also that we are using digital Doppler PCR or beaming that are very high sensitivity, but unfortunately they don't have the possibility to do panels. We need to go for single determinations. And obviously, when we are going very deep in the analysis and in the technology, we can have some problems like the clonal hematopoiesis. We have a source of false positive and false negative. We need to remember that. In the case of the false negative, the technical issues is an important concept. But in the false positive, when you are using samples, for example, for more than 6 months in the tissue compared with the blood, you can have false positive, and the contamination, and obviously the clonal hematopoiesis. The clonal hematopoiesis is a new concept that unfortunately we need to face right now, because several of the mutations that are coming from cells that are peripheral blood cells that are non-derived by the cancer can confuse our results. And that was not a problem when we are using, for example, when we are detecting JAK2 or GNAS. But now that we have, for example, KRAS, this is a problem, because KRAS is a target that we have new drugs coming there, or TP53, because it's a prognostic factor as well. So there are not at this moment any company that is doing a filter of this clonal hematopoiesis, and we need to work on that in order to don't have confusional factors. Just for finalize, my message for this session is that obviously clinical biopsy has hampered several biological, technical, and socio-economical changes in place. For example, that we don't have access covered by the insurance. This liquid biopsy is a problem. We don't have an equal accessibility for all the patients, and that is very pity. Next generation sequencing must be the preferred panels that we need to use, because we are adding the concept of commutations. Knowing the exact limitations of the liquid biopsy is very important, and obviously the blood first approach is almost here. Finally, the immunotherapy, as I say, is still the beginning of a very long journey, and there is several things to do in this exciting topic of liquid biopsy. I would like to invite you for 2 events that we are doing in liquid biopsy. One is the ILCC hot topic that will be virtually, obviously, with these times, and the International Society of Liquid Biopsy meeting that we will have both in October, and both are obviously free events, and you are more than welcome. Thank you very much for your attention.
Thank you, Professor Rolfo, for this wonderful presentation and very clear and complete. And so we are very late, so we will have one question for each speaker. And please, can you respond in a quick manner, just 30 seconds for each speaker. So the first question will be addressed to Professor Philippe. Do you think the TKI option in first-line setting is a near future for patients who are harboring EGFR exon 20 insertion mutation?
Yes, I think so. We need this. We mentioned 3%, 5% of all patients with EGFR mutations, and we have seen better results now with agents such as Osimertinib, Bothiotinib, the Takeda compound, and also the compound, monoclonal antibody against MET and EGFR. So yeah, we need to have these targeted agents in randomized trials. I think so. Yeah, we need these agents, and this will be for the near future the first line treatment in this group of patients.
Thank you.
Okay, the next question is for Professor Garrido. Does crizotinib have still a role in the treatment for ALK positive non-small cell lung cancer?
Yeah, it's an interesting question. I think that is different when you have the option to use other drug upfront or not. So it's always complicated to answer that. In my opinion, the role, if any, should be different because we have drugs that are more active in the first line scenario, not only in terms of activity, median progression-free survival, but also due to the high penetrance at CNS that, in particular in this subgroup of patients that are young patients, is really important. So, but according to some clinical cases, it seems that some specific mutation could be reverted by crizotinib. So maybe in the long term, in a specific patient in the future could be an option. But at least for, in my opinion, and in my country in general, I wouldn't say that is the standard of care that I used to be.
Thank you.
Thank you. So we have a question for Professor Rolfo. What do you think about the role of artificial intelligence and machine learning techniques in the future of patients who are harboring and who are oncogen addicted?
It's a very interesting question. I think we are seeing that in some papers, specifically in the one that I show about the early detection. So machine learning will be, or artificial intelligence will be a very good tool for that. We don't have, obviously, that in the clinical practice yet, and it's still in the area of the research, but it's a very good complement also for this technology.
Thank you.
Thank you. The last question for Professor Gagil. Among EGFR mutated patients, do you think that there is a subpopulation in which we can use or we can propose first-generation TKI and anti-angiogenics rather than osimertinib as first-line treatment?
I personally don't think that there is a subset between exon 19 and exon 21 as of now, where addition of VEGF inhibitor to first generation would be the preferred option. I will say that at least in the United States, the company that makes ramucirumab is promoting that combination specifically in exon 21 mutation. And it can be a consideration there because there was benefit seen with that combination both in exon 19 and 21. But kindly note that that was a PFS benefit, not a survival advantage. We did see PFS benefit with osimertinib as well. What we did not see was an overall survival advantage in a subset analysis. So I am not convinced as of now that the addition of a VEGF inhibitor to a first generation inhibitor is of any specific advantage over osimertinib, since we don't have that direct comparison. I would rather wait for the studies that are looking at VEGF inhibitors plus osimertinib to really make the determination. So as of now, I think I would still prefer osimertinib.
Thank you.
So thank you. We think that we can close this really golden session, and I'd like to thank every speaker and to thank everybody of you, and Dr. Proto, my co-chair, and also really to thank Dr. Garasino for this unique opportunity. Sorry for the emotion. And we will leave you with a very interesting surprise.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Hello again. So this is maybe the most interesting part of the Congress. I am joking, clearly. So you have to take this box, which is the box G. I think that most of you received the package. And inside you will find the bottle. And now we have to follow the cooking show. And at the end, we can celebrate all together with the aperitivo milanese. Thank you.
Hello everybody, we are very pleased to be here today in our kitchen to give you just a little relaxing moment in your business day. I know that you're all involved in a business affair, and what Lorenzo and I want to do is just make together with you a delicious dish and a very, very good cocktail which will give you some moments of happiness in this day. My name is Valentina and I am the cook.
I am Lorenzo, your bartender of today, and together we will prepare you something very, very delicious with the ingredients, fresh ingredients from Italy, our country, and we hope you enjoy our aperitivo. So Valentina,
Okay.
show us what did you prepare today for us?
Okay, today we're gonna make a non-cooked fresh tomato sauce with homemade stracciatella. Stracciatella is an Italian typical cheese, which is made by cutting a fresh mozzarella into little pieces and add it to a fresh cream for about 4 or 5 hours. And after that period, what we will have is a really delicious fresh stracciatella. Then we will need all the dry bread that we will put in a blender, and the result is gonna be bread crumbs that we will add with basil, oil and pepper, and what we will have is a tasty crumbs with basil. Then the most important ingredient is tomato. This is a red and mature San Marzano, a real San Marzano.
San Marzano, italiano, pomodoro italiano della nostra terra.
Because in Italy we have a real good quality of tomato. And this is very important. It has to be red and mature. When we blend it, we will have a sauce, a little thick sauce, not too liquid. And this is very important, because when we do a recipe using simple ingredients, the important is that we find the best quality ingredients. So when you go to the grocery and you will buy everything you need for this, please make sure to buy the best quality. Okay, I think, Lorenzo, I could start.
Yes, you can show us how to prepare all this deliciousness you
Are you gonna
just
help
narrated.
me sometime?
I don't know, if you want me to.
Okay, let's start with bread. Okay, let's take a bread. This is an old bread of yesterday or 2 days ago, and this makes the bread very dry. And so let's cut the bread into little pieces, little cubes.
So dry, so dry. Definitely yes, dry.
It has to be like this. Okay. And let's put it into a blender.
Okay. So just bread inside of a blender,
Yes.
nothing else.
Yes, just bread. Okay.
Lo chiudiamo, we close it up.
Okay. Then we're gonna blend it, and the result, we're gonna blend it. I have something like this. Like
You can
this.
use your regular blender in your home
Yes.
right now.
Like this. Okay. The result is gonna be breadcrumbs like this.
Wonderful, wonderful.
Okay. Not too thin. Just leave the crumbs a little big because it's much more better for the final result. Okay.
In Italy, we call it pan grattato, which means breadcrumbs that have been grated, okay?
Yes.
Italian style bread. Okay. So next step?
Next step, when we have the crumbs, we just have to add a little bit of oil.
Italian oil.
Yes.
Extravergine d'oliva.
This is extra virgin and biological oil, very good. But I am sure that in your countries you have a very good oil too. I'm very sure about it. Okay, let's add just a little bit of oil.
Just a drizzle.
Yes, just a little bit of oil. Just a little bit of salt. It's a thin salt, like this. Just a little
Okay.
bit.
Un pizzico.
Un pizzico di sale. And then take some leaves of basil,
Fresh basil.
fresh basil.
Absolutely.
Very, very, very perfumed. And this is what made me decide to choose this recipe, because Lorenzo later is gonna propose us a cocktail which is made by basil, and so which is made by gin and tangerine and basil. And so I decided to make a dish with basil, so they're gonna match very, very well. Okay.
What a food pairing we got today. What a food
Okay,
pairing.
you just take two basil leaves, you cut into pieces like this,
Very precisely.
very precise.
Bravissimo.
It took me very many years to learn to do this. Years of school to cut basil.
Wonderful. So we got the breadcrumbs, we got the basil.
Yes. Okay, let me give you a secret. If you have something like this, which is a marvelous machine for a cooker, it's a cooker machine, you can put oil and basil into a glass like this, and you can blend it, and what you will have, it's an oil, it's a tasty basil oil, which is very, very useful for many uses. For example, I use it on fish or on vegetables, on pasta, on rice.
Can you repeat, please, Valentina, the recipe?
Yes.
I will write it.
Yes, okay. You just have to put some basil leaves, some oil.
Some oil, just some basil.
Yes. Then you blend it together.
Bellissimo.
And what you will have is such a
Bellissimo.
pesto, a more liquid pesto. And this is very, very useful. I always have it in my
Pesto
kitchen.
oil, wonderful.
Yes, okay. But today I was not sure yet that you had something like this, and so we will do the easy way. Okay, so just do this. Put your basil.
So inside of the breadcrumbs.
Yes, inside of the breadcrumbs.
Okay.
Okay. And then take a spoon and mix together breadcrumbs, basil, and oil. That's it. It's very, very easy, but it's gonna smell wonderful. The smell.
Thank you. Goodbye.
Okay, okay. And let's put it apart. Okay, let me just please wash a little bit here.
Okay, so now we got, to recap, we got the stracciatella, we got the breadcrumbs, the basilico, the basil, and the basil oil. So you're gonna use it or not?
Yes, I'm gonna
Okay,
use it
wonderful.
because I can't do without.
Okay, You can do it without. Remember.
No, I can't live without my basil oil.
Okay, remember it.
I am very Italian.
Yeah, definitely. Very Italian, you know.
Very Italian.
So we now put it all together now, right now.
Okay, last thing we have to work the tomato.
You gotta cut it?
Yes.
Okay, so we cut the tomatoes.
Okay, just take one tomato.
Yeah.
Okay, let's cut into a half.
You gotta split it in half, yeah, at first.
Okay.
Look
then
how nice
cut
it is.
In another half.
So quarter down, wonderful.
And you have to take the seeds off the tomato because the seeds are a little bit heavy for digestion.
Yeah, yeah.
Okay, you will think about the tomato all night long if you eat.
That's why.
Yes.
Oh, I didn't know that. I didn't know that.
Yes, you just take.
So you just with your fingers, you gotta roll it off.
Yes, very, very easy way. Easy way. With your fingers, you take the seeds off.
Wonderful.
Then you take the middle that it's a little bit white because we want a red sauce. Really good.
That's good. Okay. So all the seeds off, the white bit off as well.
Yeah.
Okay. Pretty nice. Wonderful.
Okay. Another
one.
Little piece.
So in total, you're putting one whole tomato.
Yes. The ingredients I have today, it's made for one big appetizer, one big plate of an appetizer, or 2 small finger food dishes.
So one Italian guy.
Yeah, yes, of course. Or the Italian guy and his wife.
E la moglie.
Or friend.
Okay. So it's almost done, so you say?
Oh, yes.
Almost ready.
Done.
Almost ready. Wonderful. So next, we're gonna pair all the things, all the stuffs with the.
Yes.
You know, we got the foods right now preparing, and then I will prepare you something to drink because nobody's got an aperitivo without the drinking. You know.
Of course.
In Italy, the aperitivo is just an excuse to eat something without drinking your hand. So we're Italians. We enjoy good things like good food and good drinks. So you gotta remember, aperitivo is also drinking. So we cut the tomatoes as well.
Yes.
Okay.
And put into a glass like this. Or if you have a blender like the one we used for bread, or any blender you have,
good enough.
It's okay.
Okay.
Let me do just a little bit.
A little bit of cleanness.
Yes.
Doesn't hurt nobody.
Always work in a clean.
Remember, that's important.
Very important.
Okay, and now it's time to blend.
To blend. Let me, Lorenzo, add just a little bit of my basil oil because.
Okay. Oh, I thought you would let me.
No. I was just telling you that I'm using it.
I'm sad right now. I'm sad right now.
But you can keep me for later.
Thank you. Now I feel useless. Okay, right now, so you're making a nice sauce. Yeah. Okay.
Okay, you have to blend the tomato very well, but please don't do it too long because if you go longer, the tomato will become always more clear, almost orange, not red. I want a red one.
Okay.
Okay, just one little secret. If it happens that when you do this operation, you find that the tomato became too liquid, it's not good. Please add just some pieces of sandwich bread. I want to show you like this. My tomato was good enough, but you can add just some pieces of sandwich bread, which will make your tomato sauce a little bit thick.
Okay, so an ingredient to thicken the sauce.
Yes.
Okay.
Okay, that's it.
We're almost ready, so.
Yes, we are done.
We are done. Wonderful.
Okay. So we have tomato, stracciatella, breadcrumbs, my basil oil.
Right here.
Okay. Pepper if you like, and salt. Okay. We are ready for the final result. Let's do it.
Wonderful.
Okay, I want to prepare with you a big plate for an appetizer, just a little more quantity, and 2 small finger food quantity.
Okay.
Okay, let's take a spoon.
Ooh. That's the nice part.
And be careful not to dirty the plate.
Be very careful.
Okay.
Okay, so that's one. That's two.
That's what I just did. I dirty the plate.
It's okay, you're a chef, you can do it. And that's number three.
Yeah. Okay.
That's it.
Okay.
You gotta smack the bowl because of the, you know.
To become more plain.
Okay. Float it off. Wonderful.
Okay.
Rigorously clean. Okay.
Then you take, with a fork, a little bit of stracciatella. And you
Oh,
just
that's
put
nice.
in the plate, this. Okay. Or an easy way to do it is like this, just in the middle of the tomato sauce.
I'm amazed right now because the colors are incredible.
Yes. Okay. Now a little bit of breadcrumbs.
Yep.
Make sure you put the crumbs at the final moment, otherwise they will get the liquid and they will become no more crunchy. Okay?
Mushy.
Mushy. Then salt, pepper, and a final basil oil.
Oh my god. Wonderful.
Okay. Then one leaf.
Garnish, never forget to garnish. Food is good, but eyes, we say in Italy, l'occhio vuole anche la sua parte, so eyes needs the goodness as well as the mouth.
Okay, and this is the final result. And now, Lorenzo, it's your turn.
Okay, because of the nice plate that Valentina has cooked today, but you've cooked it too at home, I chose from all our selection of cocktails, we have the cocktail G11G that is made with fresh basil, gin, and tangerine oils. So it's a cocktail that is ready to make, it's ready to drink, so I'm sorry. You gotta just put some ice in the glass and pour it over and enjoy. So it's kind of simple, remember.
It's very easy, I can do it too.
Yeah, as well. Okay. Everybody can do it. So remember, just one rule, Valentina. You gotta fill the glass with ice. Packed with ice, because the much ice, the colder it will be, and the dilution will be the less. So your cocktail will last longer and it will be more enjoyable during the time of the aperitivo, because we're drinking slowly because we want it to enjoy. So, fill with ice, turn off the cap, open it up, like this, it's so easy. Use a little spoon that you can find at your home, not as long as this, but you can have...
In every house we have.
You can have your own, so, and just put it over. In this kind of way.
Before on the spoon and then.
Yeah, because of that, because you can avoid the splashing of the liquid.
Okay.
So because of this, that's the cocktail that is almost ready. So stir it up just a little bit to chill it, because you want it fresh, because you're drinking and you're having food, so you want something refreshing.
Yes.
In your mouth. So it's done. And to complement the food, we're gonna use a little bit of basil, fresh basil, just a little leaf, and I will share a secret with you. To express the essential oils of the basil and all the other fresh herbs like mint and other things, a little bit of a clap, uno schiaffetto, and then you can have all the perfume of the basil.
I can feel it.
Okay, that's it. So the cocktail is ready to drink. Enjoy your G11 with the full Italian aperitivo.
Yes.
Salute!
Good job.
Here you are. So take the G, take the bottle, the drink, the ice, the basil, and this is the way we are toasting with you, although in a virtual way, and I'm toasting with the chairs of today. So before toasting, go to Zoom, is on the right, the left hand side on the top. If you go to Zoom, we can celebrate all together. Con lo Zoom per colpa mia come sempre. Un minuto. Siamo di là.
Come mi aggiungo al Zoom? No, per quello, se me lo mandi.
Ragazzi, ripartiamo, se no le 2 di notte siamo Ciao, ciao, ciao. Questa...
Good evening to everybody. Do you enjoy your drink?
Good evening to the speakers and the participants, and welcome to this section of the meeting focusing on the topic of immunotherapy for advanced non-small cell lung cancer. As everybody knows, immunotherapy has been a key player on the stage of advanced non-small cell lung cancer during recent years, and it has completely changed the treatment paradigm of the disease. During this session, we will explore all the main aspects of the complex world of immunotherapy, thanks to the presence of outstanding presenters who are international opinion leaders in this field. First of all, it's my pleasure to introduce Professor Martin Reck, head of the Department of Thoracic Oncology and the Clinical Trial Department at the Lung Clinic Grossansdorf in Germany.
Hello, everyone.
Hello.
Can I have my slides, please? So it's my great pleasure to be with you, at least virtually. I would love to be personally in Milano and to share this nice cocktail with you, but I think we can repeat this at another time. And it's my great pleasure to talk to you about the achievements that we have made with the implementation of IO monotherapy in the treatment of our patients with advanced non-small cell lung cancer. So these have been my disclosures, and we have to remember when we talk about lung cancer, we are still talking about one of the most difficult and deadly diseases. The majority of our patients are diagnosed with an advanced disease, and the majority of our patients, at least the Caucasian patients, are diagnosed without any treatable oncogenic alterations. And the majority of our patients is in need of palliative systemic chemotherapy, and traditionally this has been chemotherapy. Well, this has been changed with the implementation of immunotherapy, and this really completely changed the opportunities that we do have for treatment of our patients. So we started with the implementation as a monotherapy in pre-treated patients after chemotherapy, but then we changed the way that we use immunotherapy, and we implemented immunotherapy also with very great success in our first-line regimen. And currently, first-line immunotherapy really represents the standard of care in management of our patients with advanced non-small cell lung cancer. And when we talk about the way how we implemented immunotherapy in our first-line therapy, principally, we had two opportunities. One is to look on the efficacy of a monotherapy in a biomarker-selected population. And I have to remind you that this is also our preferred concept in patients with oncogenic alterations. And we just had a very exciting session about the use of targeted therapies in patients with oncogenic alterations. Or we have the opportunity to use combinations of chemotherapies with checkpoint inhibitors or immunotherapies, and we will talk about this later. Well, when we talk about the concept of a monotherapy, what we would like to achieve for the patient is to give him a chance of a chemotherapy-free systemic treatment, to give him a chance of an improved tolerability compared to chemotherapy, to give him a chance of an improved long-term tolerability. We have to remember that immunotherapy is not a treatment for 4 to 6 weeks. Sometimes we are treating patients for years with immunotherapy. So we really have to look on the long-term tolerability of our treatments. And we also would like to expect a better impact on the quality of life by using a monotherapy. So in summary, what we would like to offer our patients is an improved maintenance of their health status in a still palliative treatment setting. Well, one of the problems is that we have to select our patients and we have to find an appropriate selection markers. And we have looked on various ways for finding a selection marker for immunotherapy. However, still we are talking about the use of the PD-L1 expression, and we have seen that there is a good correlation between the PD-L1 expression on the tumor cell and the efficacy of the checkpoint inhibitors. This is one example how this has been investigated in a prospective way. This is Keynote 001, looking on the correlation between the PD-L1 expression on the tumor cells and the efficacy by pembrolizumab. And in this analysis, you can see that the threshold of 50% PD-L1 expression on the tumor cells could be determined as the threshold for a better efficacy related to the use of the checkpoint inhibitor pembrolizumab. Well, the randomized confirmation has been done in the Keynote 024. This was a prospectively randomized trials comparing a monotherapy of pembrolizumab to a combination chemotherapy in untreated patients with advanced non-small cell lung cancer without oncogenic alterations and a high PD-L1 expression on the tumor cells. There was the opportunity for a crossover in those group of patients who are randomized to the control arm to the platinum-based chemotherapy, and this crossover to pembrolizumab was seen in more than 65% of the patients. Well, the Keynote 24 trial was a positive trial. The primary endpoint was progression-free survival, and we did observe a risk reduction by 50%, a hazard ratio of 0.5. We also did observe an improvement of the response rate, 45% compared to 28%. As expected, tolerability was better together with the symptomatic efficacy when we look on the patient-reported outcomes. And we also did observe, despite the crossover, a significant improvement in overall survival, favoring the therapy with pembrolizumab, corresponding to a hazard ratio of 0.6. Last year at the World Lung Cancer Conference, we showed the data with a longer follow-up, and we still do see a consistent benefit in overall survival favoring the monotherapy with pembrolizumab. We still do see a hazard ratio of 0.65, and now we have a 3-year overall survival rate of 44% compared to 25% in the control arm. And we have submitted the 5-year survival data to the ESMO meeting in a couple of weeks, and I really would like to invite you to look on the presentations. The data really look good. We had some additional information when we look on the long use of the immunotherapy. We haven't seen, with the longer follow-up, any change in the tolerability profile. The range of the immune-related adverse events remained the same. We have seen dynamic responses, and we also have seen that a treatment over 2 years was feasible in a group of patients. So 38 patients in the Keynote 24 trial received the 2 years of pembrolizumab by protocol. On the left side, you can see the swimmer plot. In dark green, duration of treatment for 2 years. In light green, the follow-up period. And you can see that patients remained stable without any treatment, sometimes for months, sometimes even for years. At the time of the analysis, from the 38 patients who received the 2 years of treatment, 71% were stable with an ongoing disease control without any additional treatment. In the KEYNOTE-24 trial, there was also the opportunity for a re-exposition to pembrolizumab as second course. And currently we have the first data coming in. We have data from 10 patients. We do see, even with a second exposition to pembrolizumab, a disease stabilization or response in 7 out of 10 patients. And what we also do see that this treatment may be maintained. So we do see an ongoing treatment in 5 out of these 10 patients. A controversies trial was done in KEYNOTE-42, also a monotherapy trial comparing a monotherapy of pembrolizumab to platinum-based chemotherapy, not in patients with a high PD-L1 expression, but in patients with PD-L1 positive tumors. The primary endpoint was a bit different. This time it was overall survival, and it was tested hierarchically, started in the group of patients with high expression and then going down. This was a positive trial, so we did observe a significant improvement in overall survival in the intent to treat population. However, when we look a little bit more in detail, we do see an enhanced efficacy as seen in the KEYNOTE-24 in the group of patients with a high PD-L1 expression on the tumor cells corresponding to a hazard ratio of 0.7. Last year, we have seen the results for an anti-PD-L1 antibody, atezolizumab, compared to platinum-based chemotherapy, also in untreated patients with advanced non-small cell lung cancer, the IMpower 110 trial. Again, the primary endpoint was overall survival. And when we look on the results in the group of patients with a high PD-L1 expression, this trial, these were the patients with TC free or IC free expression. Again, there was a significant improvement in both efficacy parameters in progression-free survival corresponding to a hazard ratio of 0.63 and in the primary endpoint of overall survival corresponding to a hazard ratio of 0.59, favoring the monotherapy with the checkpoint inhibitor atezolizumab. Well, in summary, we can say we do see for the monotherapy with the checkpoint inhibitors compared to chemotherapy in the biomarker-selected patients in the group of patients with high PD-L1 expression on the tumor cells is superior efficacy compared to chemotherapy in each efficacy parameter that we have investigated. And we also do see an improved efficacy in symptomatic outcome parameters and quality of life and symptom control parameters. And currently this has been confirmed in various randomized trials. There are some clinical questions. What about the impact of age? What about the impact of TMB, the impact of KRAS mutations? And then the very important question, when should we use IO combinations, even in those patients with a high PD-L1 expression? So when we look on age, we do have the data available for a pooled analysis from KEYNOTE-24 and KEYNOTE-42, looking on those patients with a high PD-L1 expression, comparing the patients older than 75 years to the patients younger than 75 years. We did observe the same improvement in efficacy, the same improvement in overall survival, independent from age. And also, when we look on tolerability, there was no difference when we look on the age of the patients. So the efficacy of the monotherapy really is independent from age. What about the use of a second biomarker, tumor mutational burden? And we had a lot of discussion about implementing tumor mutational burden in our diagnostic procedures. What we have seen here, and these are data from the KEYNOTE-42 and PD-L1 positive patients, that there was a somewhat enhanced efficacy for the monotherapy with pembrolizumab in those group of patients with a high tumor mutational burden. So for a monotherapy, potentially, this could be an additional biomarker to support the use of a monotherapy. Looking on the KRAS mutation, the efficacy was seen independent from the KRAS mutation. It also was seen in a very special type of KRAS mutation where we have a huge clinical interest by now, which is the KRAS G12C. We have a couple of potential targeted therapies which are currently in randomized trials, but also in this group of patients, we have seen a superior efficacy for a monotherapy with pembrolizumab compared to platinum-based chemotherapy in a retrospective exploratory analysis. Interestingly, there was a positive association between the KRAS mutation and PD-L1 expression as well as tumor mutational burden. Well, coming to the last question, when should we use the combination in patients with high PD-L1 expression? And I think this is a difficult area because last year at the World Lung Cancer Conference, we already had some kind of debate, and it's a bit difficult to struggle against the chair of this conference, but we have to be a bit cautious when we talk about the comparison of a monotherapy with a combination therapy, even in this group of patients with high PD-L1 expression. We have to admit that so far we do not have any prospective comparisons. The Insignia trial in the United States is going on. Also, we do not have any clear clinical or translational markers. We really have to work with our gut feeling, or I would say the art of medicine, to have to adjust the right patient to the right treatment. However, let's have a look on the data that have been published so far. First of all, interestingly, when we look on survival, in particular, when we look on the long-term survival, we haven't seen any difference between the 2-year survival rates when we look on the monotherapy trials on the left and the combination trials, the Keynote 189 and the Keynote 407 on the right. As expected, tolerability is in favor of the monotherapy, in particular when we look on the grade 3 to 5, the clinical meaningful treatment-related adverse events, and when we look on the frequency of treatment-related adverse events leading to discontinuation. The difference and the potential clinical importance is reflected in the progression-free survival curves. So we have seen that in the group of patients with a high PD-L1 expression, when we look on the monotherapy, there is some drop down in the first months of treatment, which means we are not able to control the disease in each of these patients. In contrast, when we look on the right side, when we look on the Kaplan-Meier curves of progression-free survival in the combination trials, we do see a very clear and sustainable separation of the Kaplan-Meier curves favoring the combination of the checkpoint inhibitor with the chemotherapy. And all of these patients which have been investigated have been patients with a high PD-L1 expression on the tumor cells. So my view would be that the monotherapy remains the preferred option for patients with a PD-L1 expression of more than 50%. However, until we have a good clinical or translational marker in patients with a high tumor burden, in patients with multiple metastases, a heavily symptomatic disease and fast-growing tumors, I would consider to use a combination regimen. And this is one of my patients where I was a bit afraid to use the monotherapy with a checkpoint inhibitor. This was a female patient, 58 years old, with a bulky central adenocarcinoma of the lung. And my first clinical treatment was the implementation to open the airway. She had a heavy stage 4 disease with metastasis in brain, liver, and bones. And she had a PD-L1 expression score of 55%. However, reflecting the whole clinical situation, this would be a clear example to use the combination therapy also in this situation of a PD-L1 high expression. So in summary, I would like to conclude that the view on first-line therapy of patients with advanced non-small cell lung cancer has completely changed. However, the treatment remains palliative for the majority of patients, so tolerability and quality of life remain the key endpoints of treatment. Monotherapy with pembrolizumab represents a very attractive opportunity in selected patients with the chance of an unexpected long disease control. Just to remember, we are presenting the 5-year survival data this year. We have a couple of innovative trials investigating new opportunities of chemotherapy-free treatments in patients with high PD-L1 expression, and understanding of resistance will be key for the further development. Having said this, I would like to thank you for the kind invitation to share the cocktail with you, and I would like to thank you for your kind attendance.
Thank you, Professor Reck, for your presentation. If we all agree, we could keep all questions for the end of the presentation. And now, that's a great pleasure for me to introduce our big and beautiful boss, Marina Chiara Garassino, and she will talk about a combination of chemotherapy plus immunotherapy.
So, hello everyone again. So it's my pleasure. We have always this debate with Martin Reck if it is better to use immunotherapy alone or immunotherapy in combination. But now I think that he's coming in the dark side of the moon because he's the principal investigator of the 9LA. So we will see the presentation. Here you have my disclosure. So why do we need chemotherapy? I think that Martin said the majority of the things in his presentation, because as you can see here, for the majority of treatments in first line with single agent, you can see that there is a clear crossing of the curves, both for overall survival and also in terms of progression-free survival. And this is also very clear if we look at the combination of immunotherapy and immunotherapy, where you can see this in the first case is durvalumab and tremelimumab, and in the second case is ipilimumab and nivolumab. You can see that there is an initial crossing of the curves, suggesting that for some patients, at least 30%, the single agent is not enough, also in patients highly selected for PD-L1 expression. And this is, the reason is that when we started to use the anti-PD-1, PD-L1 immune checkpoint inhibitors, we started to think only at the target and only at the tumor neoantigens. And we forgot that there is also the tumor immune microenvironment. So I think that the situation is much more complex, and we have to work not just on the tumor and also on the T cells, but also on the immune microenvironment. And in 2020, the chemotherapy is the only agent which is able to activate, to inducing the immunogenic cell death, to activate the T cells, and on the other side is able to shape the microenvironment, killing the Tregs, killing the myeloid-derived suppressor cells, and potentially also the macrophages with M2 phenotype. So on one side, we are activating the T cells, and on the other side, we are removing the negative part of the tumor microenvironment. So if we just have a look to the most relevant clinical trials that we have, you can see that the crossing of the curves when you add the chemotherapy disappears. And this is the main reason why, in my opinion, we still need the chemotherapy. Clearly, we want to avoid the chemotherapy. We want a chemo-free regimen. But I think that we need more work to identify who are the patients who benefit just of the single agent or the combination of immunotherapy and immunotherapy. This is the Keynote 189. Clearly, it is a very pragmatic trial, untreated stage 4 non-squamous non-small cell lung cancer, performance status 0 or 1. It is important to remember that PD-L1 was not powered to take decisions for PD-L1 expression. No symptomatic brain metastases were allowed, and patients were randomized to receive carboplatin, cisplatin, pemetrexed, and pembrolizumab, or the combination of carboplatin, cisplatin, and pemetrexed. There is a good proportion of patients having 30% of PD-L1 more than 50%, and most importantly, the crossover was allowed, but because when Keynote 189 was conceived, pembrolizumab was already a good second-line treatment. Here you have, and I want that you fix in your mind the shapes of these curves. This is the overall survival at the first presented interim analysis. You can see that the overall survival was not reached yet. There is a decrease of the risk of death of 51%, which was highly statistically significant. And the results were updated several times. The last one was in ASCO 2020. And as you can see, I just wanted that you remember some numbers. 22 months is the median overall survival at the final analysis, and the reduction of the risk of death, despite a very huge crossover to pembrolizumab in the chemo arm, the hazard ratio is 0.56, again, highly statistically significant. And you can see that at the end, there are still a lot of censored events, but the curves tends to close after 3 years. If we look at the results based on PD-L1 expression, this is again the final analysis, you can see that the benefit of adding platinum pemetrexed to pembrolizumab is consistent in all the three categories, so PD-L1 negative, gray area 49%, and PD-L1 more than 50%. And the hazard ratio, as you can see, they are very similar, suggesting that potentially all the categories can benefit of the combination of chemotherapy plus immunotherapy. Again, moving to what Martin said before, while it seems that there is a benefit of using the tumor mutational burden for selecting single agents, it's the value of adding to the clinical setting, the clinical utility of using the tumor mutational burden. Here you can just see the blood tumor mutational burden is not seen, because as you can see, if you add chemotherapy to immunotherapy in patients with high tumor mutational burden, you can have the same benefit that you have in patients with low tumor mutational burden. This is true for the overall survival, this is true for the progression-free survival, and this is true also for the response rate. This is the trial, the twin trial with the squamous histology, clearly a different type of chemotherapy. In this case, we have carboplatin and paclitaxel or nab-paclitaxel added to pembrolizumab again, and there was an optional crossover with pembrolizumab. The final results suggest again that although it is not statistically significant, also in this case there is a benefit in adding chemotherapy, and you can see again that there is no crossing of the curves from the beginning. Again, this is another trial. Just for reason of time, I will show you only the positive trial. This is the other triplet that we can use for the non-squamous histologies. Here we have the Empower 150, where you can have carboplatin, Taxol, and bevacizumab in the arm C, which was the control arm. In the arm B, you add atezolizumab, and in the arm A, you remove bevacizumab. Just to be short, these are the results. Again, another trial statistically significant. But you can observe that from the shapes of the curve and also from the hazard ratio that the magnitude of benefit is less than what we can observe could observe in other types of regimens. And again, if we remove bevacizumab, you can see that there is still a benefit, although it was not statistically significant, but this was an interim analysis, but again is less. So the situation also, if there is a chemotherapy better than another, is still an important issue. Moving to the most recent part, which is the combination with anti-CTLA-4, so again, something more of what we saw before, you can see some results. The first result is the Checkmate 568. This was a phase 2 trial, and this was the basis on which it was built, the 9LA. You can see chemotherapy, just 2 cycles, and the combination of nivolumab and ipilimumab. The preliminary results suggested a median overall survival of 19.4 months, which is slightly less than what we observed in the Keynote 189. But what it was very important, and this is why I'm saying that Martin is changing idea, he was the PI of this very important trial, the Checkmate 9LA. You can see that you have as a control arm chemotherapy, and in the experimental arm you have chemotherapy added to nivolumab and ipilimumab. 719 patients randomized, stratified by PD-L1 expression. Here you have the results. You can see that the overall survival is quite interesting. You don't see any crossing of the curves, in the Kaplan-Meier. You can see that the median overall survival is 15.6 months, but I remember that here we have all the histologies and not just the non-squamous where we had 22 months. But in the majority of patients are censored after 12 months. There is a minimum follow-up, more or less, of 1 year. What it is interesting to see is that there is a tail of the curves for the quadruplet of combination with nivolumab and ipilimumab, but I'm very curious to see in ASCO 2021, hopefully not online, to see if these tails of the curves will hold on time. It's interesting because the results are consistent both for non-squamous and also for squamous. And if we go and we look at the results based on PD-L1 expression, you can see that also in this case, the benefit is maintained for all the categories. But I would like to show you in particular in PD-L1 less than 1% that there is a sort of plateau, although again the results are very, very, very early, in about maybe more than 40% of the patient, which is, in my opinion, is the taste of this trial. Finally, there is also this trial, again, presented in the virtual ASCO 2020. You can see that there is a comparison of durvalumab and tremelimumab and chemotherapy plus durvalumab and tremelimumab. Clearly here we do not have a real control arm because none of the regimens are really the standard arm. But again, the results are really interesting because you can see that, again, the combination with chemotherapy, although it is not statistically significant, if you look at the curve, is always over the combination with durvalumab and tremelimumab. And again, maybe you can see better the results here, where in the blue curve, you can see that the combination with chemotherapy is always better than the combination of durvalumab and tremelimumab. So it is difficult to draw some conclusions now because we do not have, as Martin said in the beginning, head-to-head comparisons. This is what we have and what we will do tomorrow morning if the 9LA will receive also the approval in Europe and in Italy. You can see that there is, in the 9LA, the promise is the curves, the long tails of the curves. And in the Keynote 189, we have more mature data. On the other side, we have 22 months for the Keynote 189. On the other side, you have 15.6 months as a median overall survival. But the real picture that you have to compare are the two interim analyses, because they are much more similar and they have a similar follow-up. And you can see again that I think that we have we need more maturity of the data to draw final conclusions on what to do tomorrow morning. So my conclusions are that we are still learning. I believe that we need chemotherapy, and as Martin said before, I think also in some categories, PD-L1 more than 50%, never smokers, and maybe with aggressive tumors, and we can discuss maybe also in the women. But we still have some gray areas because we don't know how much chemo, we don't know how long chemo, we don't know what is the best chemo regimen. And again, we are still far for a good selection of patients for IO, chemotherapy IO, and also IO. Now we know only that we can use PD-L1 expression, we can use the tumor mutational burden, and we can't use the histology. The magnitude of the benefit of anti-CTLA-4 in general is still unclear, because we don't know what is the benefit of adding to chemotherapy plus anti-PD-L1, anti-PD-1 of ipilimumab. And I think that if the tails will hold on the time with more follow-up, I will seriously consider to use this kind of regimen in the future. In this uncertainty, shared decision-making with patients are crucial. And I'm sorry that we miss the presentation of Professor Parvettoni that will be added because we had some problems with the internet connection, and we are going to register it very soon. I would like to acknowledge again all my team, all the team of events, and my fabulous group. Thank you for your attention.
Thank you, Marina, for your excellent presentation. And now it's turn of Professor Luis Pasares from Madrid, Spain. He will talk us about a combination of different immunotherapeutic agents.
I'm congratulating Marina for putting all this event even online, which is still more difficult. And I really thank all the prior speakers for setting up the scene. Actually, as you will see in the next few minutes, I'm going to start with this clinical case, which is a patient of mine, 30 years old, with no prior history of interest, apart from being a prior smoker, that presented in a hospital close to ours with a stage 4 squamous cell carcinoma of the lung, actually with cervical spinal cord compression. The after diagnosis was treated with palliative radiation because of the spinal cord compression, and at the end of that, the patient came to us in early January 2016 asking for a second opinion. Here in the next slide, you will see how the spinal cord compression was looking like. You see the rib totally destroyed and actually the tumor getting inside to the medullary channel. And I'm just going to leave you that here because the patient came to us for a recommendation. The truth was that the patient was very interested in some kind of immunotherapy because he read on the internet that some immunotherapeutics would maybe give you the opportunity to be a long-term survivor. And actually that patient was particularly interested on that. He was 30 years old. He just married like a few months before, and actually his wife was pregnant, like 5 months pregnant or so. So he was really hoping to bet all his money to long-term survivorship. He was not very much worried about what type of toxicity he may have or whatever. And then I'm just gonna go into the dissertation. I mean, I think we learned many years ago that immunotherapy is working. PD-L1 inhibitors, PD-1 inhibitors do benefit a number of patients. Actually, we know that most of the benefit is related, or the magnitude of the benefit is related to the magnitude of expression of PD-L1, even this is not the only factor. Indeed, Martin very cleverly enriched the patient population in the first line, and we know that Pembro, first line, also Atezo now, is actually a good opportunity for patients a single agent in this very setting. Of course, I really like to highlight that at the very end, only very few patients are actually benefiting from that. Maybe long-term survivors are 20 to 30%. Even you're selecting the 25% of the patients that are PD-L1 high, more than 50%. So that means you're benefiting a lot, very few patients. That is the bottom line. So I think we have to do something to try to benefit more patients here. And there are a number of things that we have been doing. One thing is that now we are not so selective in terms of contraindications. So if a patient of us had some type of autoimmune disease, mild, moderate, which is not necessitating at the present time some immunosuppressive drugs, we are not actually precluding them to receive immunotherapy. And I think that is a very important gain. A good number of patients are now candidates that they were not some 5 years ago. The second thing that we are doing is that actually some patients with diseases like papillomatosis, HIV, and whatever, we know that is working on those patients. So we are expanding the population. The second thing we are doing, and I think Marina actually summarized that data for us, is that chemo plus immuno is actually doing better in many patients. I think those patients, regardless TMB, regardless PD-L1 expression, and the nice thing, as Marina pointed out, is that actually we are avoiding early progression. This is the main problem when we are facing a patient which is PD-L1 high, and we are not sure if giving only Pembro or Atezo is going to be the best thing to do, because some of those patients with monotherapy are actually having early progression, and some of those patients are actually not rescued with salvage chemotherapy. They do have really rapid progressions, and some patients are not rescued. So I think this is something that we have to take into our head, I would say. So the other kind of strategy has been IO, which is the main topic of my presentation. And I'm pretty sure that you remember this complex trial, which is not a trial, but a conundrum of trials itself. I think we have discussed it very much on the design of the trial, but the bottom line is that in the first analysis in TMB high patients, Ipi/Nivo did better as compared to chemo, but number of patients were pretty small, and even the curve, really the shape of the curve were very nice. It looks like there was a plateau. The maturity of the data was pretty low, so we thought, well, we have to wait to see what happened in the long term. The other thing which is interesting is the shape of the initial part of the curves. Immunotherapy without chemo, even they are dual immunotherapies, is not enough. It's not good. The first part of the curves do not look nice. You're still having the crossing of the curves. So that means you have a very aggressive disease, which is difficult to define. Immunotherapy, single agent, or combination of immunotherapy, so far is not the best strategy. And I think we have more and more data, if time to say so. The survival data initially looks like TMB didn't work. The trial was positive, formally in PD-L1 positive patients. Actually was also showing benefit in PD-L1 negative, which is maybe the more remarkable point. But the data, the magnitude of the benefit was not outstanding, I would say. Even the data for PD-L1 negative was very clear. But as I said, the magnitude of the benefit was the same in TMB high, PD-L1 high patients as compared to TMB lows, PD-L1 lows. So that means double positive and double negative benefited the same. So we do not have clear biomarker here. And I think this is of interest as well. Nicely, last year, we have seen the data at 3-year follow-up with a median follow-up of 43 months. And you see here that, again, the long-term data suggests that there is a clear plateau on the long term. Of course, still, those data should mature, but as you see, PD-L1 positive patients, 3 years follow-up, survival at 3 years, 33%. You go to the PD-L1 negatives, the same data, 34%. Particularly relevant here because what you expect with chemotherapy here is only a survivorship in the range of 15%. PD-L1 negative patients treated with chemo do have worse prognosis as compared to PD-L1 positives. So here the magnitude of the benefit is higher in terms of immunotherapy. The other important thing is that you have this curve in between, which is the Nivo plus chemo. I understand Nivo chemo is not a standard regime, but it's a regime of chemo plus a PD-1 inhibitor. And you see here how the benefit is actually losing power, is losing strength after 18 to 12 months, or to 24 months. And you see that the end is actually going back to join the chemotherapy curves. So I think this is something that makes us to really reflect where may be the benefit of a regime like that. Importantly, look at the data here. That is, as we said, not nice what happened at the beginning of the curve, particularly what happened at the end. But importantly, if we go and look at the response, we have part of the explanation here. And I think it's very important for you, I think, to look at this data. 1 year duration of response for responders, 64%, nearly 40% at 3 years. And actually, PD-L1 negative, very similar data, nearly 70% duration of response at 1 year, nearly 35% at 3 years. So most of the benefit is because of the high quality of those responses with double immunotherapy, particularly relevant in PD-L1 negative patients. And I think this is something that we have to see. That is not actually reproduced with chemo-IO. You see that here, particularly in PD-L1 negative. The quality of response is much worse. Of course, as I said before, this is Nivo chemo, not Pembro chemo. Importantly, what about toxicity? Well, toxicity, as expected, this regime, the Nivo 3-EP1 is much better tolerated than the old regime with high EP, but still is toxic. I would say overall it's not more toxic than chemo, at least this is my perception. But as you see here, the number of patients needing discontinuation is double. 9% chemo, 18% Nivo-EP. But remember, those patients in Nivo-EP were for 2 years. So the probability of being discontinued is not for 4 months, it's for 2 years. So maybe that should be also taken into account. Importantly, the toxicity of Ipi-Nivo, the typical immune adverse events, do happen for most of the cases during the first 12 months. After that, is not affecting more than 5% of the patients. Overall, you have to be monitoring those patients because the side effects may be potentially important, but most of the patients do not have significant toxicity later on. When looking at the data of those combos in other diseases like small cell lung cancer, the data are not that beneficial, and I think that's good enough. And actually, when you see other combos, and I think Marina mentioned that, like the Treme, Durva, the data are not quite yet there. And indeed, when you combine with chemotherapy, which is the next wave of treatments, let's say, the data are not pretty appealing in small cell lung cancer, And in non-small cell lung cancer is the data that also had been presented. And I really like to remark another couple of aspects here on the NILE trial that Dr. Reck led very brilliantly. Remember that in this trial, some 719 patients were recruited. Importantly, there is no crossing of the curve, so only 2 courses avoids the crossing of the curves at the beginning. The second important thing, which was behind the hypothesis, if you look at 1 year, the difference between the control arm and the experimental arm is actually 16% in numbers in survival, 47 versus 63. If you look at the 227 trial, because patients on ipi/nivo were progressing in the first few months, the difference in survival is only 7 points, 7%, not 16% as here. So I think that is a very, very important initial signal. Still, the data are pretty mature. What is going to be really important is what happened at 3 and 5 years with this type of regime. The other important thing that also mentioned Marina is that survival is actually across all the relevant subgroup of patients, including histology, regardless the type of PD-L1 expression. And I think PFS is also confirmed in this trial. And importantly, as you will see here, duration of response. This is some of the data that is somehow intriguing to me. Look at the data. Chemo-IO, the rate of response is maybe higher here, so more patients are responding. Particularly, you're avoiding some early progressions, but the quality of response, I'm not sure is that good as with ipi/nivo. So those responses due to chemo maybe are not as durable as those responses due to ipi/nivo. In fact, look at here, at 12 months, duration of response 49% is not 69% as it was on the ipi/nivo trial. So maybe here, this is part of what we need to really look at in the long term in that very trial. I think this is a very important point, at least for me, when the data of this trial is maturing. However, one of the critics of this trial that I'm not agreeing with is about toxicity. Actually, the regime is pretty well tolerated for most of the cases. Of course, you're having some tox, but look at the big data. Number of patients needing to discontinue, 19%. Remember, ipi/nivo, 18%. So the toxicity is not at least the severe toxicity is not increasing that much. And I think those are part of the data that we should take a look at in the future as the data are maturing. And because so far the data are very similar to the ipi/nivo. Of course, it's been mentioned that we have to look at the Poseidon data, the chemo plus durva-treme. We haven't seen the data with the durva alone. We haven't seen the data with treme plus durva. I'm eager to see how those data are actually being combined with those of the non-LA, particularly taking into account that not only 2 courses of chemo, but more were given in that particular study. One of the last studies I'd really like to briefly mention here is the CITYSCAPE. In that case, the combination of 2 immunotherapies, but not a CTLA-4 inhibitor with a PD-1 inhibitor, but an anti-TIGIT with a TISO as compared to a TISO alone. This is on PD-L1 positive patients, phase 2 trial. Of course, the rationale is pretty clear because the immune mechanisms through these inhibitory signals are very parallel, very often concurrently happen through TIGIT and through a PD-L1, and therefore, I think the rationale was very strong in that very case. And the data suggested that the response rate is increased only in the population with PD-L1 high, and the same is true for progression-free survival. Interesting in that case, for those patients treated with atezo, the data were not great. So we have to see what happened in the phase 3 trial, if this difference in PFS is actually being maintained, or some of the effect is due to the underperformance of atezo in this small data set, only 30 patients per arm. So some of those data have to be thought about. The last thing is that another way to combine chemotherapy, two immunotherapies, is actually to combine two strategies in one single drug. And this is a very good example. This bispecific molecule targeting PD-L1 in one arm and trapping TGF-beta, another very important microenvironment immunosuppressive signal. And as you see here, response rate is much higher when using that combo as compared to Pembro, at least comparing to historical data in a second-line setting. And the survival curves suggest that even in patients with immune-excluded tumors are pretty high. Look at the data here, particularly in the 12 milligrams cohort, are pretty significant. Survival is exceeding 15 months in PD-L1 positive patients, and is actually not reached in PD-L1 high, more than 80% of the expression tumor. So I think this is a very convincing strategy for me, and some phase 3 trials are ongoing in the stage 3 setting, and a large phase 2 on the stage 4 setting in the first line as compared to pembrolizumab. And of course, some other studies have to be studied. I'm just putting here some of the CART strategies plus PD-1 inhibition, and some others with TILs and so on are to come baby, not mature at the present time. So just to finalize, just let me to think a bit on, I think we have to learn a bit more on how to better implement the best immunotherapy for each of our patients, depending on the patient and the tumor profile, the immune profile, the genomic profile, the patient expectations, comorbidities, and so on. And just before finishing, I'd just like to go back for maybe 30 seconds to my clinical case. You remember, 38 years old, stage 4, squamous cell carcinoma of the lung, spinal cord compression, came to us before starting first-line treatment and asked us for a treatment recommendation. And actually, at the time, what we did was to include that patient in the 227 trial, the checkmate, and he was randomized to ipi/nivo. And here is what happened. That patient actually had an excellent response. You see here after 2 courses, nearly all disease is gone. And you see the bone of the vertebra was starting to be rebuilt. And this is what happened in the last CT scan that I saw some 3 months ago. And the patient is really in complete response, totally disappeared. You see the initial here is totally perfect. And actually the patient is again on in the next picture you see is incomplete responses. To be honest, I saw the patient this morning in the clinic, so I could add some 3 months of follow-up, nearly 5-year follow-up. So the patient is nice. Is actually expecting for next week the second child, and I think is actually claiming for another important issue to be discussed with our patients. So sometimes patients really like to bet on different expectations. So if I have a patient which is 85 years old, maybe long-term survivorship is not going to be my first goal. But if I do have a patient which is very young and he's really like to do anything to have the highest probabilities, at the present time we have not data comparing one strategy to the other, but maybe this is the patient that I may consider for a strategy where long-term hope is a good alternative. And I think this is my last slide showing that unfortunately we have very little data on the long-term follow-up. We are hoping to see the data that Dr. Reck promised on the checkmate, on the keynote 024, and some of the other data that are coming at 3 and at 4 years in the trials that have been commented here today. And that's all for the present for this presentation, and I hope to be able to discuss any questions you may have in the roundtable at the end. Thank you.
Thank you, Professor Passares, for your presentation. And now we leave the floor to Dr. Filippo De Marinis, head of the thoracic unit at the European Institute of Oncology in Milan. Dr. De Marinis will give us an overview on the topic of the future of immunotherapy for advanced non-small cell lung cancer. Due to technical reason, Dr. De Marinis could not connect with the meeting, but he sent us a video with his presentation.
So, good evening. Many thanks to the chair and thanks to Marina for your kind invitation to your international meeting. I'm sorry, but we have some technical problems, some firewalls in our intranet of IO that allow our live participation. So I am recording this presentation this morning. And the title of my presentation is The Future of Immunotherapy in Advanced Non-Small Cell Lung Cancer. This is my disclosure. This slide shows the evolving landscape of immunotherapy in non-small cell lung cancer, starting from 2015, where the first checkpoint inhibitor were registered in the second line of non-small cell lung cancer. Just to this year, when new immunoagent as atezo in first line and PD-L1 patients or combination, a new combination of immuno and chemo were presented, opening a new scenario for the role of immunoagent. But if it's clear that we gained using different techniques or immunotherapy as single agent or in combination with other immunoagent or in combination with chemo or in combination with other immuno and chemo agent, we gained an advantage in comparison with the standard chemotherapy. But at the same time, it's clear that we needed some other advantages because the difference between the ideal goals and the results obtained using immunoagents is too much. So we need about a new combination, and this limitation to the use of immuno combination that up to now we are using is given by some mechanism of immuno resistance. So some intrinsic to the tumor mechanism or some mechanism extrinsic to the tumor. And if we analyze the tumor intrinsic mechanism, the tumor cell alteration are affected from the neoantigen expression, from the antigen presentation, from some inhibitory signals. And if we consider the tumor extrinsic mechanism, the host immunostatus and tumor microenvironment is affected by T cell priming, from antigen recognition, from immunocell recruitment, from co-inhibitory and co-stimulatory signals. So if you want to play a role in favor of the new combination, we can overlap this resistance, and for this some potential strategies to overcome this resistance are under evaluation, or removing the co-inhibitory signals, or supply to the co-stimulator signals, or conditioning the tumor microenvironment, or increasing the T cell priming, or doing something against the gut microbiome. So if you analyze the different strategies, we can consider the removal of co-inhibitory signals. We have a different possibility to inhibit some signals as TIGIT, S15, LAG3, VISTA, and these co-inhibitory signals and this ligand are expressed on the T cell, on the antigen-presenting cell, and their activation is responsible of immunosuppression. So, using some antagonist antibody of the co-inhibitory molecules, these have some potentiality to restore the immunocompetence. About the co-inhibitory signals, TIGIT represent a new possibility to be inhibited, and the phase 2 study Cityscape presented at the last ASCO meeting showed the possibility for tiragolumab, this new inhibitor combined with atezolizumab, to be evaluated versus atezolizumab with response and PFS as primary endpoint, and the study showed an advantage for the combination with tirazolizumab and atezo with a very interesting hazard ratio versus placebo plus atezolizumab, with an increase in overall response, an increase in PFS, especially for the patients with an high expression of PD-L1 over 15. And the new phase 3 study, Skyscraper, is ongoing. Another co-inhibitory signal is S15, was originally identified as one of the cyclic gene family members with well-defined role in osteoclast differentiation and bone remodeling, abundantly expressed in human cancer cell and tumor-associated myeloid cell macrophage, very involved in some immunofunction. S15 and PD-L1 are mutually exclusive in non-small cell lung cancer, and different phase 2 trials are combined now, combining immunotherapy and NSCLC, a new inhibitor, an monoclonal antibody of S15 with some response positive results. LAG3 represent another co-inhibitory signals. This function are negative for the regulation of T cell and for the track differentiation of CD4 T cell. Very present in 30% of surgical non-small cell lung cancer samples, associated with a negative outcome in non-small cell lung cancer. And the combination of LAG3 and PD-1 anti-monoclonal antibodies demonstrated synergistic improvement, and a phase 1 study with anti-LAG3 antibodies with or without PD-1 inhibitor are ongoing, including also non-small cell lung cancer. VISTA is another function with a ligand and a receptor that are negative role for regulation of T cell, for a track differentiation of CD4 T cell, and is present in more than 90% of the non-small cell lung cancer samples, and the levels of this protein are very expressed and correlated with the level of both PD-1 and PD-L1 in whole tumor tissue sample. So dual VISTA and PD-1 inhibition with oral CA170 has demonstrated a disease control rate very interesting in predicted patients. Another strategy to overcome the resistance is given by the supply of co-stimulator signals. These co-stimulator signals and their ligand are expressed in tumor cell and APCS and immunocells. Their activation is responsible of immune activation. We have several agonist antibodies of co-stimulator molecules that has potentiality to increase immunocompetence. So OX40 is one of the members of TNF receptor superfamily expressed on activated immunocell, and upon induction it mediates cytokine production, survival, expansion, and homeostasis of effector or memory T cell. An intratumor injection of OX40L mRNA was well tolerated and showed accuracy activity in a phase 1-2 study in solid tumor, including non-small cell lung cancer, and the molecule combined with atezo in a phase 1b study is MOX-0916 with a very preliminary results. CD137 is another member of TNF receptor superfamily involved in some negative immuno life of the cell. Utomilumab is a fully human agonist of CD137, demonstrating a safety and preliminary anti-tumor activity in monotherapy or monotherapy, or in combination with pembrolizumab in this phase 1b study, obtaining a decreased control rate more than 75%. CD40L, GITR, CD278, ICOS agonists are all members of TNF receptor superfamily, and for the inhibition of this receptor, several phase 1 studies are ongoing with this kind of agonist. Another strategy, another potential strategy to overcome the resistance is given by the conditioning to the tumor microenvironment. So the tumor microenvironment is very dynamically influenced by a large number of mediators, enzyme, oncogenes, cytokine, growth factor, and the immune activation within the tumor microenvironment can be therefore enhanced by selectively targeting these specific factors. One of these factors is IDO, an intracellular enzyme that catalyzes the first and rate-limiting step of the tryptophan degradation and the chironin pathway, where the local tryptophan depletion and increase in downstream metabolites inhibits T cell activation and drives TREG differentiation. Analyzing one of the IDO antagonists, we found epacadostat, that is at the basis of the ECHO program, with different studies in previous treated patients or in naive patients. ECHO 202 is a phase 1-2 trial of epacadostat plus pembrolizumab in pretreated patients, obtaining a response, a decreased control rate more than 50%, but in combination with pembrolizumab versus pembrolizumab, two ECHO trials failed to demonstrate an advantage for epacadostat. Histone deacetylase are transcriptional regulators of cytokine angiogenesis, cell cycle, and apoptosis. They are involved in inflammatory cytokine regulation, IDO increase, T cell activation, TREG increase. So we have different studies where vorinostat and entinostat, two histone deacetylase inhibitors, were combined with the pembrolizumab in pretreated patients, obtaining a very interesting response, more than 50%. Another nuclear receptor transcription factor represented by ROR gamma that expressed in 40% of non-small cell lung cancer samples, and E agonists directly the lower PD-1 expression and function, the decrease of co-inhibitory molecular expression, the decrease of TREGs in tumor microenvironment, enhance pro-immunochemokine and cytokine, enhance expression of co-stimulated receptor, increase the effector cell. And we have some encouraging data on safety and response from phase 1-2A monotherapy studies with LIC 55 716 ROR gamma agonists, including non-small cell lung cancer patients, and we have some other studies in combined with pembrolizumab with an interesting 60% of response. CDK4 and 6 are some other cyclin D kinase, and we have some other trials using abemaciclib, an inhibitor on this cycline, combined with pembrolizumab that demonstrate to be safe in phase 1b trials in non-small cell lung cancer with a decreased control rate of 50%. The tumor microenvironment is modulated also by a large number of cytokine, and this protection by the tumor cell and immune cell in the tumor microenvironment can imbalance the homeostasis of immune response, leading to recruitment of immunosuppressive cell and reduction of activated cell, and it's possible to see a large number of potential target and compound inhibitor of this target that are under evaluation. One of these is represented by canakinumab in the Canopy project and the Canopy different Canopy trial. In canakinumab can inhibit EL1 beta, and canakinumab significantly reduced the incidence of lung cancer in a previous Canto study. And Canopy 1 is concluded for the enrollment study, very fast from the enrollment in these phase 3 trials, where canakinumab was combined with chemo standard pembrolizumab versus chemo and pembrolizumab. So we are waiting for the final result of this study. Another large series of altered oncogenic pathways can modulate chemokine and cytokine production and interferon gamma signaling and the PD-L1 antigen presentation, and can result in immunosuppressive tumor microenvironment. So we have some oncogenic targets combined to immunotherapy that are under evaluation in phase 1-2 trials enrolling non-small cell lung cancer. Angiogenesis and the vascular endothelial growth factor can stimulate the mobilization and the selective accumulation of amyloid-derived suppressor cell within the tumor site, and the VEGFR is a very well known target, and the bevacizumab, chemo, and the atezolizumab recently demonstrated efficacy in Empower 150. So several other several VEGFR inhibitors as ramucirumab, lenvatinib, and nintedanib are currently in clinical trials both in first line setting and after immunotherapy resistance in non-small cell lung cancer. Finally, T-cell priming can be enhanced by stimulating antigen presentation or antigen recognition to and this represents another potential strategies to overcome resistance. We have TILs, so the tumor infiltrating lymphocyte that are cell collected from the patient's tissue, harvested, expanded, and selected according to specific tumor recognition. The selected Ts and then expanded and reinfused in patients after lymphodepletion. This is the design of one of the study presented recently at the ACR, a phase 1 trial of TIL adoptive cell transfer. TILs collected, the selection, nivolumab was administered, and the patients in progression after 4 cycles of nivolumab received the lymphodepleting treatment, and 10 the TIL reinfusion, and 10, and then the nivo restart with a very interesting response in this trial. We have also the CAR T-cell is a very large, problem, especially used in hematologic malignancy, and the use of CAR T-cell can found some several limitation in solid tumor. Is a very specific argument I am not able for present the results up to now obtained. Then we have some personalized neoantigen vaccine that are designed based on the patient's neoantigen and the HLA profile. We have some preliminary results of very experimental first line phase 1 study where neoantigen vaccine are combined with chemo and pembrolizumab that and the study are ongoing. Finally, the good microbiota that play an essential role in development and the regulation of adaptive and innate immunochemokine cytokine modulation, so the possibility to modify the specific gut microbiota composition may influence the response of immuno agents, and there are a very large number of studies using this kind of agent. And if this is the increasing of the number of immunotherapy targets and the studies realized in 2 years, is clear that the next year we'll see a large number of immunotargets using some of the possibility that I show you to potentially overcome the resistance in immunotherapy. But if we need of new the new molecule, the new agent, and this is my last slide, and I want to introduce Professor Kerr, and I use one of his slide. If we need for a new molecule, the new agent, at the same time we need about biomarkers, because we can save for useless treatment with our patients. We can save from the toxicity, we can save from financial toxicity. So I think that the development is very linked in the molecule and biomarkers, and this can represent the future of immunotherapy. Thank you so much for your attention.
Finally, from Aberdeen University Medical School, Professor Keith Kerr will talk about biomarkers for immunotherapy.
So good evening, everybody, and thank you very much for the invitation to participate in this this meeting. It's, as everyone else has said, just such a shame that we cannot meet in person. And thank you very much to the earlier speakers for setting the scene around the clinical aspects of immunotherapy. And it's my job to discuss some aspects relating to the use of immunotherapy. So I'm going to discuss really four key questions. The first one is there actually evidence that the tumor is likely to be immunogenic? This would be the first question as a basis to the biomarker approach that we have taken. So going straight in to this particular question before we move on to immune response, the presence of the drug target, and then factors which might inhibit the immune response. Is the tumor likely to be immunogenic? And this question really relates to the use of tumor mutational burden, which statistically speaking will be associated with greater tumor immunogenicity if some or even one of those extra mutations within the mutational burden codes for a new protein which is clonal and which is able biochemically to act in an antigenic fashion. It also requires the tumor cells to be able to process that protein and present it as a neoantigen on the surface of the tumor cell. This is what determines immunogenicity. And we know very well that our lung cancers are amongst those tumors which are potentially very highly mutated, although there is a very wide range from tumors with very low mutation to tumors with a very high mutational burden. And as you've heard alluded to by some of the other speakers, there are lots of studies out there that have looked at tumor mutational burden, and in general, TMB is able to enrich a population for improved response to immunotherapy, anti-PD-1 or anti-PD-L1 agents. It's fair to say, however, that the majority, if not all of these studies, have involved retrospective analysis. And to the best of my knowledge, TMB has not been used prospectively in a phase 3 clinical trial to date. This slide also shows us that some of these trials were based on whole exome sequencing, whilst others were based on large panel analysis. We've also heard from some of the previous speakers about how there have been issues with some of the trials in delivering an overall survival benefit relating to selecting these patients with either tissue or indeed blood-based TMB. And also, a bit like PD-L1, which I'll discuss later, the selective power of TMB appears to be lost when we get into using chemo-IO or other IO-IO combinations. So whole exome sequencing is not really a practical biomarker in the clinic, but perhaps we can use these large diagnostic panels, some of which are illustrated in this slide. The big question, though, is which panel are we going to use? Because they're all quite different, and they measure TMB in a different way, leading to a deal of confusion. How many mutations do we need in our so-called small panel in order to deliver a reasonable estimate of overall tumor burden? We also know that from some of these studies, the way that the data are analyzed, the presence of cancer genes may actually bias the estimation of overall tumor mutation burden. And actually, what is a mutation in this context? Because lots of different aberrations may potentially lead to neoantigens. And the way in which the data are analyzed from the next generation sequencing output will determine what alterations are considered a mutation versus those that are not. Some of these studies consider the tumor mutational burden measured against the presence of germline. In other words, subtract germline alterations, but not all of the studies, all of the methods do this. We also know that the clinical tissues we use are prone to producing artifacts. And then there is this difficult issue of clonal hematopoiesis-derived mutations giving what might effectively be considered as false positive measurements. We also have not really decided yet what is a high tumor mutation burden and what is the cutoff that we should use, although many studies have come to use 10 mutations per megabase as a measure, particularly when they're measured according to these small panel tests. But we still have not figured this out, nor have we figured out what is the best way to measure using these small panel methodologies. And there are underway right now some comparative studies looking at different platforms to see whether doing TMB this way versus that way is better or worse. And so far, the indications are relatively promising. Another question that comes up is, how low can we go? In other words, how small can our panel be and still give us meaningful TMB data? We do know that the fewer mutations we look at, looking for a mutation, the less predictive of overall tumor mutational burden the data are likely to be. And certainly it looks like sequencing less than half a megabase probably is invalid. And yet there is one study at least out there claiming a very small 24 gene panel might actually give a relevant or accurate estimate of tumor mutation burden. And then there's a question of whether specific mutations mean something. And we've heard already about KRAS or KRAS plus P53 mutations actually enriching for responses, whereas KRAS plus LKB1 mutations or the presence of a KEAP1 mutation might actually act as a resistance mutation, a resistance factor. And we also know that essentially EGFR or ALK altered lung tumors also are probably relatively resistant to immunotherapy. And then can we refine the TMB concept further? Because TMB is a rather blunt instrument. It's quite a crude measurement. Can we nuance our sequencing data to try to predict better neoantigen load? Because that's what really matters. And there's some indication that perhaps we can. Perhaps we can also predict the probability of neoantigens through loss of HLA heterozygosity. Our neoantigens need to be clonal rather than subclonal. And we also know that frame shift mutations are actually more likely to generate neoantigens than some other types of alteration. And finally, slightly different from what we've been discussing, our sequencing data may also give us data on TCR clonality, which may also predict for response, which takes me quite conveniently to the next question, which is there actually evidence of an immune response that we can reactivate with our therapy? Because if there is no immune response available, our immunotherapy is unlikely to work. And this brings us to the question of measuring inflammation in the tumor. And somewhat perversely, the lung cancer world so far has concentrated on molecular inflammation, looking for immune gene signatures involving interferon gamma gene expression, PD-L1 gene expression, and others as a measure of tumor inflammation. And indeed, this approach does work. We've seen it in a number of lung cancer trials. But this is quite a tricky biomarker, and most of the data are based on fresh tissue, which is not really a good way to go in clinical practice. But could a rather more simple investigation of inflammation using a microscope actually give us the same information? We know this is so for other tumors like breast cancer, colon cancer, and melanoma, but there's little or no good data in lung cancer. Or could our examination of inflammation be more specific, looking at the types of immune cells that are present in the tumor, or where in the tumor these cells are located? And ultimately, using multiplex examinations down the microscope or using digital technology, can we look at multiple markers to nuance this decision? And I'll come back to this at the end of my presentation. So moving on to the thing that we're most familiar with, which is PD-L1 expression. Is the drug target actually present and active in the patient's tumor? Because if it's not, the drugs are much less likely to work. Several of the previous speakers have mentioned already that consistently PD-L1 expression appears to enrich for response, particularly from monotherapy, and the more PD-L1 you have in the tumor, the more likely there is to be a response. And for many of the drugs and combinations that we've seen, this data may be regarded as complementary and is not a companion diagnostic. The only companion diagnostics currently are for pembrolizumab monotherapy, where in Europe it's a 50% cut point. In the US, it's currently a 1% cut point. And then in Europe, potentially for the use of durvalumab in stage 3 disease, we have the 1% cut point. I would remind you, when it comes to these cut points in the context of a biologically continuous variable, which is our biomarker, with increasing biological efficacy as the concentration increases, that when we select a group of patients for treatment using a cut point, the patient treatment group is still very heterogeneous, especially when the cut point is set very low. And we often do not see data presented to us in this fashion, looking at different groups with different levels of expression, which will give you a much clearer view of what is actually going on. And this demonstrates how even within the 50% or more cut point, there is still some biological heterogeneity. And indeed, in some studies, we've seen academic studies from the US, a 75% cut point has actually been proposed for monotherapy. Interestingly, also from the IMpower 110 trial, we now see the return of the TC3 IC3 category, potentially for atezolizumab monotherapy. Which does bring us to the question, really, what are we measuring? Is it PD-L1 in tumor cells, which is, of course, what we are currently doing with the 22C3 assay or the SP263 assay, perhaps with the SP142 assay, and in general, we get excellent inter-observer correlation from pathologists in this context. But for immune cell assessments, which are present in some of the studies, either alone or in combination with tumor cells, very poor inter-observer correlation. So we know that we have lots of drugs, each with their allied biomarker, and we've struggled to understand how to use the tests. And in most pathology labs, we're only going to be able to use one test. And unfortunately, that single test might not even be one of the trial validated assays, and we may have to develop our own tests. So we need to compare the behavior of these tests. And there are many, many studies now that have done this. And I show only one example from the ISLC Blueprint series, showing us that essentially the 22C3 assay, the 28-8, and the SP263 assays are essentially very similar. The SP142 assay is much less sensitive. The 7310 assay, which is associated with avelumab, is much more sensitive. So what we do in practice, many laboratories use the 22C3 assay because of its association with pembro monotherapy. But an equal number of labs, probably in Europe, are using the SP263 assay as a transferable equivalent. Many fewer labs have been using the SP142 assay because of its lack of sensitivity, but this will be an interesting debate given the IMpower 110 data. And the use of LDTs as an alternative brings into question a lot of issues about quality, which I'll come to in a minute. So how similar are these assays? For 22C3, SP142, probably in most people's hands, similar enough to be clinically interchangeable. There have been some studies that suggested that SP263 might identify more patients positive, a study from Australia shown here, but equally on the other side of the argument, the UK NECWAS data are beginning to show that actually perhaps SP263 assays detect fewer patients as positive. So the jury is really out on this one. One thing for sure is that the 7310 assay definitely will make more patients, in quotes, positive. And this is why, as Luis referred to, the high cut point for the 7310 and the avelumab trials is 80%, which is probably equivalent to the 50%. And is there clinical data to allow us to validate using an alternative biomarker to the one used in the trial? Well, the answer to that is not very much. We've seen here studies from Japan suggesting similar clinical outcomes regardless of the biomarker used. And here also in the OAK study, we did see equivalence between SP142 and 22C3 in terms of clinical outcome, although it was a different group of patients that were selected by the different biomarker. Quality is absolutely essential, and this should include internal laboratory quality assessments and external quality assurance. In the laboratory, you can check to see if your lab is doing okay by just looking at the number of cases that you are allocating into the three groups, less than 1%, 1 to 49, and over 50. It should be approximately 1/3 in each group, with probably rather fewer cases in the central 1 to 49 group. And this has been shown by a number of studies now demonstrating this bimodal distribution. The other thing to note is that the 1% cut point is a really much more challenging cut point for pathologists to agree upon. It is a tough call, that's for sure. So what samples do we use in our studies? Well, actually, we rarely have a choice. We use whatever is available. There's debate about whether primary versus metastatic disease would be better, but there are no data to suggest that we should concentrate on one rather than the other. Do we use a new biopsy or older archival material? Again, no good data to influence practice other than perhaps to say that we should avoid tissue that is very old. And there was long debate about the use of cytology samples, but the bottom line for me is cytology samples are absolutely fine and work very well. The important thing is we have at least 100 tumor cells to use in our assessment. And here are data from my own lab showing that 9% of our clinical samples, when our first 1,000 samples failed the 1,000 cell, the 100 cell threshold. And unfortunately, rather more of those were in the cytology group than in the biopsy group. And it's important that we have at least 100 cells because there are data shown here that if we call a PD-L1 score on less than 100 cells, the clinical outcome efficacy of that call is lost compared to an assay with more than 100 cells. Our PD-L1 assessment may be confounded by a number of things, including heterogeneity and sampling error. If immune cells really matter and we're not assessing them, that may be a problem. But I just wanted to mention briefly this issue of intrinsic induction of PD-L1, because it reminds us that some patients in the bottom right-hand side of this scheme here show those patients who have no inflammation in the tumor but have a high PD-L1 expression, which may not be related to an immunological adaptive response, and it may instead be induced by cellular mechanisms within the patient's tumor. And finally, I want to mention very briefly, there are other factors which may inhibit the immune response, and Dr. De Marinis actually covered much of this. The central tenet for using anti-PD-1 and PD-L1 therapies is that this reaction is inhibiting an existing available inflammatory response which has reacted to neoantigens in the tumor. But around this, in the tumor microenvironment, there are many different factors which potentially may offset the effect of the drug. And within this group, there are potentially many other things which may become biomarkers for us in the future. So in the future, will we use one biomarker or will we use any biomarker at all if combination therapy is what we are going to do in the future? The strategy that we undertake will not be perfect, but we hope it will be practical and affordable. And I will make this my last slide, an interesting systematic review and meta-analysis from the US showing that potentially the use of multiplex immunohistochemistry might actually be a better predictor than TMB or expression signatures or PD-L1. Only the time will tell as to whether we use this in the future. Thank you very much for your attention.
Thank you very much, Professor Kerr, for your presentation. Now we'll see if there are some questions from the public.
We would like to thank again all the speakers for the brilliant presentations. And if there are no questions from the audience, I have a question for Professor Reck. Professor Reck, during your presentation, you mentioned a hot topic in the field of immunotherapy, that is the duration of treatment. Basing on literature data, do you think that today we can define the optimal duration of immunotherapy single agent for advanced non-small cell lung cancer? Are data we have enough to support an optimal duration of 2 years?
Well, I think this is quite a difficult question, and we do not have a good answer. The decision to treat patients 2 years with pembrolizumab in the keynote trials was not really based on scientific data. And for example, in Germany, we have the problem that the label of pembrolizumab is not related to 2 years of treatment. It's related to the duration of response. So we can treat even patients longer than the 2 years. And what we have seen in the clinical trials, and this is something which I like to transfer also into my clinical practice, that there are some different type of responses to pembrolizumab. So in the majority of patients, indeed, we had a duration after 2 cycles or 2 or 3 cycles of treatment. The median time to response was 2 months. But when you look on the individual patients, in particular the patients who are receiving for a long time pembrolizumab, you do see that there are some patients who do respond slowly over time, and we even had 2 patients qualifying for a response after 2 years of treatment. So I really think we have to look individually on the patients. What I do is, if I have a good response after 2 years and I haven't seen any significant changes, I go for a PET-CT to see whether there are some metabolic activities, and then I really discuss individually with the patient whether I should stop or not. But I think we clearly need more data to define the appropriate duration of response, and I'm not convinced that we have a good answer for everyone.
Thank you.
I have a question a brief question for Professor Pazzares. Also considering data about a combination of immunotherapy plus chemotherapy, who is the right patient to receive ipilimumab? We have some problem with audio.
Sorry, I was mute. Sorry about that. So that was difficult to hear me. Okay, so the question was about which patient is for chemo plus ipi-nivo.
Yep. Or just nivo plus ipi. Who is the right patient to receive ipilimumab?
All right. So it's not an easy question because we have very little data on the long-term follow-up of all trials. I think maybe in 1-2 years, when we 5-year follow-up of all those trials, Keynote 189, the 024, the 407, and so on, it would be a bit easier. Even it's going to be always a cross-trial comparison. Today, what is nice about the 2 to 7 trials is that in the long term, it looks that there is a plateau. And that is consistent with the biology of the intervention. I mean, CTL4 is an inhibitory signal that is actually acting very much on the memory of the immune memory. So it makes sense that it really prolongs long-term survival. We have data on other diseases where the combination with PD-1 inhibition, it really prolongs long-term efficacy. So at the present time, because of uncertainties, so we are not sure that chemo plus ipi-nivo is any better as compared to chemo-nivo, chemo-pembro, let's say. I would really mainly go for 2 subsets of patients. That would be long discussion with a patient that is really PD-L1 negative. I think it would be a nice patient to discuss with. Of course, if the patient is having aggressive disease or so on, I will not give only ipi-nivo, but chemo plus ipi-nivo. But of course, you need, first of all, the regulatory approval. And of course, discussing with the patients, it should be clear that we are not sure at the present time that the benefit is there as compared to chemo pembro, let's say, for example. But that could be a typical patient, young patient that is really betting for long-term survival. That could be, and particularly the negative patients. That could be my main target population.
Okay, thank you very much. And then, Marina, in Italy, unfortunately, the combination of immunotherapy plus chemotherapy is not refunded in patients with PD-L1 expression over 50%. If is it possible to give to our patient this combination in a patient with PD-L1 over 50%, which kind of treatment do you suggest? Just pembrolizumab or a combination of chemotherapy plus immunotherapy?
So thank you for the question. I think that also Martin and also Luis said a lot of things about this. There is not a clear answer because we have just indirect comparisons. But if we look at the meta-analysis, we can see that overall there is always a benefit of chemo plus IO, which is not feasible. So I think that there are patients with a very aggressive disease, and in particular also never smokers, that maybe can benefit more of the combination of chemotherapy plus immunotherapy. And some patients with a more indolent disease, maybe smokers, that I think that for them, I'm sure that maybe pembro could be enough. I think that we have to discuss very well patient by patient. And I think also that this is just for Italy. I don't know in the other countries that it's not correct that a regulatory agency change the indications if one trial, for example, the Keynote 189, but also the other trials have as an endpoint the overall survival for all comers. So I think that as a scientific community, we have to advocate for having the drugs approved as the trial was done, and then decide as physicians, case by case, what is the optimal indications. This is just my view. Thank you.
Thank you, Marina. And I have a question, a simple question for Professor Kerr. Given that PD-L1 is the only biomarker we can use in clinical practice, commonly in clinical practice, would you recommend us the best antibody for testing its expression? Because we have to know. I know it's a strange question.
Is necessarily that simple. I think the issue really comes down to whether you as oncologists are using the PD-L1 data, how you're using the data. And there's been a lot of discussion, understandably and rightly so, about perhaps using the information more to nuance your decisions, to decide what to do with your patient, rather than using it as a strict selection criterion based on the 50% cut point for pembrolizumab monotherapy, and that's the only thing you're using the information for. There's certainly argument for wider use of the PD-L1 data, but however it is done, you have to be confident in your own practice, in your own hospital, that it is performing adequately in the laboratory that you're using. And when the pathologist tells you it's 50% or it's less than 1%, then that's correct, or it's an accurate representation as compared to when if your patient was tested in another hospital, perhaps using a different assay. And this really strengthens the argument, therefore, for using one of the commercial assays as opposed to making your own LDT, your own laboratory developed test. So, you know, I think that if you have the choice and you have the money, the funding, the two best routes to go down are either to use the 22C3 or the SP263 trial validated assay, because it's controlled by manufacturers, and if it's applied appropriately, you should get consistent results. It's very difficult to say more than that.
Thank you very much. So, if there are no more questions, in the conclusion of the first day of our Congress, I would like again all speakers for their excellent presentation, in particular our boss Marina for the opportunity to moderate such an exciting debate and international event. So, see you tomorrow for the second round of our fight. Good night and good luck.
Thank you very much. Good night.
Thank you.
Thank you very much. Thank you. Bye.
Bye-bye. Bye-bye.
So in Italy now it is night. I would like to conclude the first day all together. I really hope to see you all in person, because I miss you, and I think that we miss the interactivity, but I hope that this live session with the cocktail and with the question could create a similar live situation. So I'm waiting for you tomorrow at the Italian time. It is again 5 o'clock p.m. and we will have another exciting day. So I would like to acknowledge also events, and I would like to acknowledge also all the pharma companies that supported our event, the cooking show, and all the people behind this day. Thank you so much.